Subcommittee on Health will now come to order, and due to COVID-19, today's hearing is being held both remotely and in person. For members and witnesses taking part remotely, microphones will be set on mute to eliminate background noise. Members and witnesses, you will need to unmute your microphone when you wish to speak. Since members are participating from different locations at today's hearing, recognition of members for questions will be in the order of subcommittee seniority. So keep that in mind. The documents for the record should be sent to Megan Mullen at the email address that's been provided to your staff. All documents will be entered into the record at the conclusion of the hearing. The chair now recognizes herself for 5 minutes for an opening statement. Underfunded and under threat. That was the Associated Press and Kaiser Health News indictment of the U.S. public health system based on their award-winning investigation last year. The investigation found that since 2010, spending for state public health departments dropped by 16% per capita, and spending for local health departments fell by 18%. At least 38,000 state and local public health jobs have disappeared since the 2008 recession. Our hollowed out public health system explains why we've seen COVID-19 cases tracked using fax machines and COVID-19 vaccines recorded on little white paper cards. These antiquated methods are embarrassing for our country that once had a globally respected public health system, and our disarrayed data collection has broader consequences for so many Americans. It's allowed racial health disparities to flourish without intervention. And as the common maxim goes, you can't manage what you can't measure. The 13 bills our subcommittee is considering today begin to rebuild our public health systems beyond pen and paper data collection and inconsistent definitions. Several of the bills use data to help our health systems improve the overall health and wellness of local populations rather than treat individual sickness. I'm proud to co-lead with Representative Peters the Health Statistics Act, which directs the CDC to develop uniform public health data standards for state and local health departments. Put simply, public health data is a mess. A striking example is the incomplete and inconsistent COVID-19 case counts and death tallies, which is addressed by bills authored by Representatives Castor, Spear, and Barrett. Beyond COVID-19, inconsistent public health data have been raised repeatedly as an issue before this subcommittee in hearings. An example of this is that there's not a single standard for how to define a gun death or maternal death. My legislation with Representative Peters carries out several recommendations from the GAO and the National Academies of Science to make vital health statistics electronically available and comparable. Robust and accessible public health data is a critical tool for state and local officials in their efforts to address the social determinants of health that perpetuate the inequities in our communities. Representative Barragan's Improving Social Determinants of Health Act builds and complements the Health Statistics Act by authorizing a new CDC program that would use the improved and available health data to address structural challenges such as unsafe housing, poor transportation, or food deserts. The remaining bills work together to use public health data to address health disparities starting at conception through childhood and into adulthood. I'm proud that our subcommittee is once again leading the charge in a bipartisan way to promote health equity through evidence-based, data-driven policy. Taken together, these 13 bills will make real and lasting change to rebuild our public health system so we can address both new health emergencies like COVID-19, as well as the systemic issues of poverty and inequality. The chair now is pleased to recognize our ranking member of the subcommittee, Mr. Guthrie.
Madam Chair, this is Burgess. I wonder if I could just ask for a point of personal privilege before Mr. Guthrie is recognized.
Certainly.
Several people on this subcommittee are old enough to remember when we had a different subcommittee chair, and it was at that time that I was assisted so ably by my young staff. Elizabeth Allen is going to be leaving my office now. She's accepted a position at Boston College to get an MBA, and it is quite a step, needless to say, quite a step up for her. We have all benefited from her experience and her knowledge over the time that she's been associated with the Health Subcommittee's work. So I thought if I could, I'd just like to acknowledge the service of Elizabeth Allen, and perhaps we could give her a brief round of applause.
Absolutely. Thank you. And we thank her for her wonderful service and wish her well. The chair now recognizes the wonderful ranking member of our subcommittee, Mr. Guthrie.
Thank you, Chair SU, and thanks to Elizabeth, and always enjoy working with her as well. So thank you for your hard work and good luck at Boston College. And thanks for holding this important hearing today. Before us today, we have several bills pertaining to social determinants of health, as well as collecting health data. I look forward to hearing from the witnesses regarding these bills. As currently defined by the CDC, social determinants of health are conditions and places where people live, learn, work, and play that affect a wide range of quality of health and quality of life risks and outcomes. I have seen and heard firsthand the benefits that Medicare Advantage can do to help address social determinants of health for seniors. For example, a recent study showed that Medicare Advantage plans continue to offer benefits that help Americans with their social determinants of health. Specifically, the study found 27% of Medicare Advantage plans offered in-home services, 57% offer meal delivery, 57% offered transportation services, and 11% offered home modification. Additionally, they found that 94% of plans now offer telehealth as a base benefit. These benefits can continue without policy changes or site of service restrictions post-pandemic. Since 2015, I have led the bipartisan member letter in support of Medicare Advantage. In 2020, we had over 300 members sign the annual letter to HHS in support of the program. It has been a bipartisan effort, and I want to take this opportunity to thank Representatives Cardenas, Blumenauer, and Kelly for all of their hard work on this letter. Medicare Advantage has demonstrated how successful private insurance plans can be if given the proper flexibilities. That is, if my colleagues do not force Medicare for all on all Americans and take away this choice for nearly 29 million beneficiaries. Nearly half of the eligible Medicare population that is estimated to choose MA for 2022. Medicare for all would prevent Americans from choosing this option that provides quality health care and supplemental services and helps address social determinants of health. Medicare for all will lead to worst case scenario for seniors, longer wait times, and diminished patient control over their own health care. Today, we're considering several health data bills. Useful health data is important, but some of the bills before us today are too narrow in scope and are duplicative of current efforts. In addition, it does not seem there is a consensus on who needs to collect what data, how it will be used, and who will have access to it, and how to do that in a way that doesn't add more administrative expense. COVID-19 shed light on the need for more public health data infrastructure, and we must use lessons learned to prepare for future pandemics rather than continuing to focus on COVID-19 specific authorities and programs. For example, H.R. 778 would establish new CDC grants to states that choose to develop and use digital contact tracing technology for COVID-19, which seems duplicative of programs that have already been funded in response to the pandemic. CDC has already received funds to do just that, and we should first evaluate how those funds are being spent. Additionally, H.R. 791, the Tracking COVID-19 Variants Act, includes provisions that would require the CDC to issue guidance regarding collaborations and data sharing for COVID-19 sequencing, while further enacting a pilot program by expanding existing data linkages. Data sequencing is already being done on variants today. Further, H.R. 976, the Ethic Act, would retroactively require states to report specific COVID-19 data to the CDC as a condition on receiving certain COVID-19 funding. Currently, states are already required to report some of this data. I'm looking forward to examining and building on ideas like Mr. Curtis's bipartisan legislation, H.R. 3969, which would allow spending on social determinants of health to be included in health insurance plans' medical loss ratio calculation, so to encourage Medicare Advantage and Medicare managed care organizations to take further action to support social determinants of health. I support Dr. Burgess's bill, the Social Determinants of Health Data Analysis Act, which will require GAO to report on the actions taken by the Secretary of HHS to address social determinants of health. In closing, I hope we can work in a bipartisan way to improve America's public health infrastructure so we're better prepared and ready to address the next pandemic. As we continue working, we need to ensure Americans' hard-earned taxpayer dollars are being used efficiently and not on duplicate efforts. I look forward to having a productive discussion today and on how to have better health care data and address social determinants of health. And I yield back my time.
The gentleman yields back. The chair now is pleased to recognize the chairman of the full committee, Mr. Pallone, for his 5 minutes for an opening statement.
Thank you, Chairwoman Eshoo. Throughout the COVID-19 pandemic, federal, state, and local public health leaders have faced barriers to collecting and assessing the data needed to fully respond to a public health crisis. It's this vital data that provides government officials and health leaders the critical insight needed to develop the best guidance in response to public health crisis. And as a result of these barriers, public health departments at all levels of government have at times lacked the information they needed to better understand the significant impacts of the pandemic on our most vulnerable communities. Unfortunately, the U.S. public health surveillance infrastructure was fragmented and inconsistent long before this COVID pandemic. Insufficient funding, limited resources, inadequate training combined with differing state and county laws, and non-existent data standardization procedures are several of the many factors that limit public health data. The slate of bills we're considering today will make targeted improvements across three key areas. First, we'll discuss establishing a uniform federal strategic action plan, as well as data standards and a data sharing policy. Second, several of the bills we're considering will improve the collection of public health data that reveals the drivers of health inequities. And third, we'll discuss proposals to assist states in the creation of a public health data infrastructure necessary to appropriately deploy resources and essential interventions. I want to commend the chair and the sponsors of these bills for their leadership on advancing policy solutions for some of our country's most pressing health policy concerns. Public health data is essential to the health of our country. It may not seem very interesting, but it's very important. This data allows us to understand which communities need resources, how many and when. It allows us to better target health inequities and address them accordingly. Public health data also gives government and local leaders the ability to make upstream policy changes and implement prevention work. Now, many of the bills we'll discuss today also address the importance of better understanding and researching social determinants of health to improve the overall health status of the United States. These bills take steps to eliminate the lingering health inequities that exist and burden some of our most vulnerable communities. Uniform data collection is imperative to better understanding the inequities in our healthcare system and to guide real change. To effectively adapt interventions designed to advance health equity, we have to be able to standardize and collect data related to key social conditions. We'll hear from the witnesses today about legislation that will help give states the tools they need to design effective interventions to address certain social determinants of health. These interventions will also improve the health and well-being of some of our most vulnerable populations, including by expanding access to evidence-based tobacco cessation treatment through the Medicaid program. And finding comprehensive solutions to our fragmented public health data is of the utmost importance. With resources that Congress has provided through the COVID-19 relief packages, including the CARES Act and the American Rescue Plan, we know that data modernization is underway. And we must now continue that work to ensure that research labs, providers, and public health departments are working with real-time current data and have a better understanding of social determinants of health. So I look forward to hearing from our witnesses and working together with our colleagues on these legislative proposals today. Chairwoman Eshoo, I just want to say to you and a ranking member, we're now, the pandemic hopefully is winding down, but the pandemic showed us that whether it was the public health infrastructure or the data collection, I'm talking about state labs, the supply chain, so many things that really showed that need a lot of work and didn't work well during the pandemic. And so I think that I just want everyone to know that myself and the members of this committee, and I know you in particular, Ms. Eshoo, we want to get to the bottom of this and make sure that we're better prepared in the future for future pandemics. And that's going to mean a lot in terms of, things that maybe don't sound very interesting, but are important, like data collection, like infrastructure for public health, like the state labs, like the supply chain. It's only if we can improve those things that we can be better prepared for future pandemics. And I just want to stress that today. I don't know how much the media cares about this, but it's very important. It really is, and that's what I wanted to stress. So thank you. I yield back.
And it's exactly why we're bringing these 13 bills forward and have the outstanding witnesses that are with us today to give us their opinion, given their background and experience. The chair now is pleased to recognize the ranking member of the full committee, Congresswoman Cathy McMorris Rodgers, for her 5 minutes for an opening statement.
Thank you, Madam Chair. Social and economic conditions have a powerful influence on our health and well-being. Dependable transportation, job security, and access to healthy foods are all factors that make a difference in the prevention and management of many conditions like diabetes, heart disease, and obesity. Today, 9.3 million Americans are currently on the sidelines and out of work. Unemployed individuals are more likely to suffer from illnesses such as high blood pressure, stroke, heart attack, and arthritis. Unemployment leads to worse health outcomes on average for all workers, regardless of their baseline measures of health. It's a cycle of despair that must be broken to promote healthier families. We need to get Americans back to work. People need hope and a purpose. It means more than a job. It's about dignity and the opportunity for a better life. And we're only at the beginning of understanding the impact of the pandemic lockdowns on mental health. This is a crisis. One hospital I talked to said social isolation is the biggest concern for seniors, not to mention the rise in mental health emergencies that we've seen for our children. For hope and real results, we should be looking to how the private sector and communities are leading the way for healthier futures. In my district, to help people without transportation, Washington State University partnered with Range Health to purchase a mobile health unit to provide primary care, non-invasive procedures, and preventative screenings for underserved rural communities. Some rideshare apps are also allowing eligible patients to order rides to and from doctor's appointments, often paid for by health insurance companies. Meal delivery services are also helping seniors access nutritional food, and Medicare Advantage offers coverage options for these services. According to a recent CMS report, 60% of Medicare Advantage beneficiaries are enrolled in a plan that offers food assistance. The number of seniors that choose Medicare Advantage plans offering these supplemental benefits like food assistance, housing, pest control tripled between 2020 and 2021. I look forward to listening to and learning more from our witnesses today on how Medicare Advantage flexibilities are helping address social determinants of health in our seniors, and what more that we can do to incentivize the private sector. In 2021, Medicare Advantage plans covered 26 million people, which is a little over 40% of the entire Medicare population. Seniors from all walks of life are choosing these private-run plans over government-run fee-for-service plans. They're spending less and getting better preventative care because of it. I'm extremely concerned by proposals from my Democrat colleagues that would ban Medicare Advantage plans and move everyone to a one-size-fits-all government-run plan. The federal government should provide incentives and enable the private sector to tackle these social determinants in ways that empower local communities. However, as we look at data policies, we need to be very clear with the American people about who is collecting what data and how it will be used. Some of the bills today authorize enormous sums of money before we even have a clear understanding of what the private sector, state, local, and federal governments are already doing and what is working. That approach may work in scoring some political points, but it doesn't drive results. I also have concerns continuing short-sighted COVID-19 specific legislation. I recently spoke with former CDC Director, Dr. Redfield. He said that the big pandemic is yet to come. We don't know that it will be coronavirus, pandemic flu, or something entirely new. We need to be working on preparing data systems and public health for all threats, not just COVID, and take into account where these systems are after the large investment and lessons learned from COVID-19. We should be empowering innovative methods that are backed by trusted data to address social determinants of health. Doctors, hospitals, state and local governments, community groups, and health insurers are leading the way, tackling social determinants of health. We need to enable their continued leadership and success and remove any arbitrary roadblocks. I'm looking forward to today's discussion, and I yield back.
Gentlewoman yields back. I thought I knew just about everything in terms of benefits in Medicare Advantage. I didn't know that pest control was one of them. The chair would like to remind members that pursuant to committee rules, all members' written opening statements will be made part of the record. I now would like to introduce our witnesses. Dr. Karen Desalvo is the Chief Health Officer for Google Health. She previously served as the Acting Assistant Secretary for Health and the National Coordinator for Health Information Technology at HHS. Welcome, Dr. Desalvo. We're thrilled to have you with us. Dr. Ramila Batra is the Chief Medical Officer for the SCAN Health Plan, which is one of our nation's largest not-for-profit Medicare Advantage plans. Welcome to you. Ms. Beth Blauer is the Assistant Vice Provost for Public Sector Innovation and the data lead for the Johns Hopkins University's Coronavirus Resource Center. Welcome to you. We look forward to your testimony. Dr. Faisal Syed is the National Director of Primary Care for ChenMed, which is a fully capitated primary care practice for seniors. He's also testifying on behalf of the America's physician groups. Welcome to you, and we all look forward to your testimony. And Dr. Kara Odom Walker, who is the Executive Vice President and the Chief Population Health Officer for the Nemours Children's Health System. So welcome to each one of you. The entire subcommittee is very grateful that you have agreed to testify. And Dr. Desalvo, you're recognized for 5 minutes for your testimony, and please unmute.
Thank you, Chairwoman Eshoo, Ranking Member Guthrie, and distinguished members of the committee. I appreciate the opportunity to appear today. My name is Dr. Karen Desalvo, and I'm a physician and former local and national public health official who has spent my career working at the intersection of clinical care, public health, and digital innovation to improve the conditions in America's most vulnerable communities. Currently, I serve as the Chief Health Officer at Google and remain engaged in efforts to address the public's health collaboratively, including through my role as co-convener of the National Alliance to Impact the Social Determinants of Health with former HHS Secretary Michael Levitt, and as a member of the Robert Wood Johnson Foundation National Commission to Transform Public Health Data Systems. Today's hearing takes place at an historic moment as we chart the road to recovery from the greatest public health emergency in over a century. I applaud the subcommittee for their leadership during the pandemic and for advancing a bold vision for public health transformation that intersects with data modernization and health equity. The vision recognizes how COVID-19 pulled back the curtain on the structural failings that contribute to inequities in our current public health system. Chronic underfunding, obsolete digital infrastructure, and long-standing capacity gaps. I have seen these shortcomings firsthand. That's why I believe building resilient and equitable public health systems begins with cross-cutting solutions, a theory of change that is captured in the Public Health 3.0 framework. I'm excited that many of the proposed bills in today's hearings share this ethos and offer the following recommendations to inform the subcommittee's vital work. First, while data analytics and IT infrastructure are important, it is imperative that legislation and policymaking focus on the systems that collect, exchange, and act on data, rather than the data itself. Recently proposed legislation for the Public Health Infrastructure Fund highlights the stable foundation of resources that health departments will need, from infrastructure upgrades to workforce investments and operational design. Second, public-private partnerships can maximize the value of data for governmental public health. There are numerous examples of such partnerships during COVID-19. To optimize these beyond the pandemic, we need to develop data infrastructure within public health focused on racial and rural disparities, like the ones proposed in the bills today. Third, achieving equity requires expanding our understanding of what data can be useful. Projects like our Google COVID-19 search symptoms trends show how public health can leverage novel data signals in a privacy-preserving manner to inform research and public health decision-making, such as where to dedicate more resources. In addition, data systems aimed at addressing inequities should integrate sources from the social and human services sectors. Fourth, data systems need to be built to describe and address inequities, not only at the individual level, but at the system level too. For example, knowing that kids in a certain neighborhood are unhealthy is just one step, but understanding where kids might not have access to sidewalks and playgrounds could help communities take action. Fifth and finally, the CDC's Data Modernization Initiative would benefit from incorporating the lessons learned from high tech. The opportunity is to do more than rewire the current 20th century public health systems, but to reimagine it. 21st Century Cures articulated such a vision by advocating the use of open and non-proprietary standards and FHIR-based application programming interfaces, or APIs, for the healthcare system. The same can be used for public health. We should also ensure that states and localities are not rushed in spending the funds and that they have an appropriately resourced workforce to maximize impact. In closing, I want to reiterate my thanks for the opportunity to testify and emphasize the critical importance of the topics covered in today's hearing. I look forward to working with the subcommittee on opportunities to strengthen our nation's public health infrastructure to achieve health for all equitably. I look forward to your questions.
Thank you very much, Dr. Desalvo. Next, Dr. Ramila Batra. You're recognized for your 5 minutes of testimony.
Thank you so much. Good morning, Chairwoman Eshoo, Ranking Member Guthrie, and distinguished members of the Health Subcommittee. My name is Ramila Batra. I'm a primary care physician and Chief Medical Officer of SCAN Health Plan. Thank you for giving me the opportunity to address how SCAN addresses social determinants of health, what supplemental benefits we provide, and our recommendations. My remarks will briefly cover who we are, how do we serve our members and our communities, and our focus on the older adult population at large. SCAN stands for Senior Care Action Network. We were founded in 1977, and we are a not-for-profit MA plan. We are a mission-based organization, and our mission is keeping seniors healthy and independent. And the true story is it was started by 12 angry seniors who truly believed there was more to health than doctors and medications in nursing homes. They wanted to age in place and live in their communities. They were the true pioneers who knew why social determinants of health needs are so important to be fulfilled. And since then, we have taken care of that population. We have provided special needs plan, and we are the only plan in California to offer fully integrated dual eligible special needs plan. We serve about 220,000 beneficiaries in California, and we have been consistently CMS ranked 4.5-star plans. So we really pride on the quality of care that we provide. Addressing social determinants of health is really important to improve health outcomes, as these factors represent 70% of the drivers affecting a person's overall health status. We see that in studies, we see that also in our data. So our approach to addressing social determinant of health is identifying what the social risks are, stratifying our population so we can match them with programs and benefits, serving our members and clients, measuring the impact, scaling the programs, and as a not-for-profit organization, running our own community-based organization in the community that serves older adults and their caregivers. In terms of identification, we have consistently done health risk assessment to gather not only health data, but also social needs data, as well as demographic data, that's race and language, including newly started sexual orientation and gender identification data. We have data on 90% of our population on their race and language, which really helps us serving them better. In terms of stratifying and serving them, we offer different programs. I would like to quickly highlight one of them. It's a member-to-member program where we take our own members, who then are our employees, train them in motivational interviewing. They then engage with our members, help them around social isolation, addressing their social needs, mental health. Last year, we were able to reach out to about 10,000 of our members through this program, had a very high adoption rate of 50%, and saw a statistically significant improvement in things like incontinence, falls, physical activity, and social isolation. On the other extreme, we also have programs like Connecting Provider to Home, where we have a social worker and a community health worker from a community that addresses the needs of the top 1% of our population who have high social burden and high medical burden. A quick story of Mr. M, who lived in a mobile van, had a history of falling, did not have access to food, did not have access to resources to pay for his utility bills. Our community health worker was able to step in, help with filling out forms for application for Medi-Cal, get assistance from community around utility payments, able to connect them with benefits around food, as well as able to go with the doctor's appointment to help with the DME. Those are the kind of things that make a difference in terms of their health outcomes. We continue following our data to find where there are unmet needs and addressing our supplemental benefits to address them. In terms of our supplemental benefits, we are very grateful for the Congress for helping us do the flexibility. Because of the flexibility, we are able to offer multiple benefits. I'll highlight one of them. It's called the Return to Home benefit, which addresses the needs of older adults getting discharged to their home. We provide in-home caregiving, meals, homemaking services, care coordination to pick up that medication, as well as caregiving support. Finally, my recommendation would be that as a not-for-profit MA plan with a long history of serving older adults, these are very important needs. We ask that Congress include SDOs such as food insecurity to the criteria for supplemental benefits more broadly than only specific chronic conditions. Finally, we recommend you consider supporting HR 2166, ensuring parity in MA pays for audio-only telehealth bill. Wi-Fi access became a huge social determinant of health need during the pandemic, and digital divides were huge. So we truly believe this can make a difference. There's also a Senate companion bill ensuring parity in MA audio for audio only that we would also like to recommend. On behalf of SCAN, thank you for your ongoing commitment to improving the care for older adults. We welcome the opportunity to be a resource to members of this committee if we can be of service. Thank you again for the honor to speak before this distinguished committee. Thanks.
Thank you, Dr. Batra. I think that it would be really helpful if the witnesses, because this is a legislative hearing, and with the extraordinary experience and background that you all have, if you could weave into your comments, if you think we are hitting the mark with any one of these bills, any suggestions, critiques, comments about them, I think would be most helpful to the members of the subcommittee. Next, Ms. Blower. It's a pleasure to welcome you again. Thank you. And you're recognized for your 5 minutes of testimony.
Thank you very much, Chairman Eshoo, Ranking Member Guthrie, and members of the subcommittee. Thank you for inviting me to participate in today's hearing and for dedicating your time to an examination of the role of data and health outcomes. My first job in the public sector was nearly 2 decades ago when I worked as a juvenile probation officer for the state of Maryland. I left the state after leading an ambitious cross-government data initiative that was credited with significant outcomes for residents, ranging from marked reductions in infant mortality, nation-leading school performance, and record low crime rates. Since 2015, I've led a center at Johns Hopkins University focused on building the capacity of local leaders to use data to improve outcomes. And for the last 17 months, I've been the data lead for the Johns Hopkins University Coronavirus Resource Center. I've seen the very best and the very worst of data use. The bills that are the subject of today's hearings go a long way to realign federal resources with interventions that are proven, measurable, and focused on ending multi-generational health and well-being disparities. In the last 18 months, governments at all levels did something incredibly remarkable. They built data collection efforts, shared data, and made real-time decisions based on near-time data. Never before has the nation endeavored to realize a coordinated effort around data sharing, data-informed decision-making, and collective outcome measurement at such scale. Local and state governments used every possible lever to stall the spread of this disease, including the very difficult decisions of closing businesses and schools. What has this last year taught us about using data to collectively solve problems? At the Johns Hopkins Coronavirus Resource Center, we became a trusted resource for millions of viewers worldwide. Over the course of weeks, JHU developed a methodology for scraping public data and encouraged state and local governments to share their data in standardized ways. JHU data scientists set up an internal governance and articulated standard collection methods under the guidance of public health and medical experts. We openly shared the entire process with the public. By January 2021, we had accrued more than 1 billion views. Our audience included news outlets, local governments, and everyday people that were making deeply personal decisions about how they would navigate their public lives. The backdrop to our entire pandemic experience was and continues to be a hunger for sound, publicly available data. This Congress has an opportunity to capitalize on the public demand for data, the financial investments we have already made in data infrastructure, and the newly minted analytics skill that has emerged across government during COVID-19, and improve upon the systems to provide accountability, accessibility, consistency, equity, and sustainability. But there are some lessons that I can offer that have been helpful over the course of my public sector career. First, we need data standards. The first instinct when you consider strengthening a data practice is to think about IT modernization or tools. But the truth is, one of the most important elements of a strong data practice is actually in the governance and the alignment of creating
on the data. I would say the other important component of the data systems is to feel more comfortable using novel signals. This is the imperative in the 21st century. And there's work that for example, using information on public sentiment, or in our case, we've made available the search symptoms trends data that can give information about what's on the community's minds. And the way I used to go into the church hall and talk to folks, it's another way to get more quantitative information that's anonymized and private to augment other data systems. And it's more timely, actionable, granular than the kind of data that most public health has right now.
That's fascinating. Let me ask Ms. Blauer and Dr. Desalvo, in both of your written testimonies, you say that hospital data is some of the most reliable data. And Dr. Desalvo, I was especially struck by your point that hospital records are what enabled health officials to sound the alarm about the Flint water crisis. So my question is, why is hospital data so reliable? And how can we make this data more widely available to local health departments? I'm assuming that there isn't interoperability between the public agency and the hospitals.
Congresswoman, in the HITECH Act, we invested resources to digitize healthcare. So now we have relatively reliable data in the healthcare systems that we've already shown can be used for public health crises like identifying Flint. There's a system in New York City that can identify chronic disease. And in Massachusetts, there are also systems that can look for communicable disease outbreaks. So there are some examples where we know that data is helpful in identifying public health challenges. The reality is also that in high-tech, public health wasn't resourced to be able to receive that data and anonymize it and make use of it in the way that Dr. Blauer has, for example, in some of the work that she has done to create dashboards that really they can be useful to the community and to the country. So it's an untapped resource but there are some great examples. I might even call it Oklahoma, another state that's been using EHR data to look for public health challenges. But it needs to be scaled. We need to do more to make sure that those systems are interoperable. And this is an historic opportunity, and the bills that you have before you begin to move in that direction to really think about designing with a standardized approach and being able to make that information useful, not just for individuals, but also for the public's health.
Most helpful, most helpful. Thank you. The chair now recognizes our wonderful ranking member, Mr. Guthrie, for your 5 minutes to question.
Thank you, Madam Chair. I appreciate that. Appreciate the recognition. Actually, if you look at Mr. Curtis's bill, he's looking at changing the medical loss ratio to incentivize spending on social determinants of health, such as Medicare Advantage plans do, and I think Medicaid managed care does as well. Dr. Burgess's bill looks at collecting data on social determinants of health so that we can use this information. I think what Medicare Advantage does is important. In order to lay out what private health insurance plans, if they had the flexibility, would do. And I have a couple of questions. One, Dr. Batra and Dr. Said, if you could address this, and I know the reality of it, but one of the criticisms which I think is inaccurate is that if you have Medicare Advantage plans, they you cherry pick who's in your plan. And therefore, obviously, if you're a health insurance company, if you could cherry pick healthy and not people with other conditions. But it's quite the opposite with the flexibility incentives that Medicare Advantage has. And I think, Dr. Said, you talked about that in your testimony, and Dr. Batra. So you talk about just kind of reemphasize, given the flexibility you have in Medicare Advantage plans to spend money on social determinants of health, one, that you're bringing in people that have chronic conditions, that are sick. And not only are you bringing them into your program, but you're giving them far better services than they get in the Medicare fee-for-service plans. Could you address that one, the criticism of cherry picking, if you do, which I don't think that you do, and the other one is how your plans are structured that are so much better for people with chronic conditions, like Mr. Curtis's bill is trying to allow health insurance companies to do with their medical loss ratio flexibility. So Dr. Batra, if you would go first.
Sure. So we serve about 15,000 duals, so that tells you out of a 220,000 population, 15,000 are in to a fully integrated dual eligible special needs plan. We also serve folks who are LICS folks, so low income subsidy folks. We serve folks who are in social vulnerability index 4 and 5. So we serve all swaths of population. If you look at the social HRA that I spoke about 10 to 15% of our people have indicated when we do their initial HRAs that they are food insecure. We have 2 to 3% people who say they are housing insecure. We have people who say who are transportation insecure. So they're people from all backgrounds. In terms of how we address their needs is through our supplemental benefits. We offer in-home benefits that include meals. We have a third of our population that complains of living alone and falling. We have benefits where we send an occupational therapist in their homes so they can help with safety and be able to mobilize better within their own home setting. So those are two very high-level examples. Transportation is a big issue. If you're an older adult, especially during the pandemic when you wanted to get vaccinated, you wanted to have access to that ride that would take you to where you needed to get the vaccine. That's the other benefit that we bring across. 90% of our membership more or less uses medication, and 90% of that membership takes a $0 medication. So that's what we also bring is that affordability to them so they can really, and those are the people who can use that benefit. So we do serve people from all walks of life.
Thank you. And Dr. Saeed? If you'd like to address it. Okay, thanks.
Yes. ChenMed goes where the need is. And my biggest challenge ever since I completed residency training has always been access. And I've learned with Medicare Advantage that Medicare Advantage opens the door. I mean, I'm able to give my patients and their families my cell phone number. They call me if they're feeling, like my wife likes to say, a little icky. And if I need help getting a patient to stick to a treatment plan, I'm able to call their kids and grandkids for backup. My team texts my patients daily about health, simple messages like reminding them to get a flu shot or staying hydrated on a hot summer day. We even call our patients weekly. We call them love calls. Even if our patients feel good, we make them feel better just by saying hello. And I'm able to see my patients at least on a monthly basis. This is how we're able to prevent little problems from becoming big ones. When I think about the social determinants, I think about food insecurity.
Unfortunately, I only have about 18 seconds left, so I apologize. I just want to kind of summarize and tie this to the legislative hearing that HR 976 giving private insurance plans flexibility within their medical loss ratio will allow other plans like Medicare Advantage to social determinants of health spending that are important to the health care, even though it may not be directly to their health care spending, but the things that matter on people being healthy, and that's why I think this is important discussion. So thank you very much, and I appreciate it, and I yield back my time.
The gentleman yields back. The chair now recognizes the chairman of the full committee, Mr. Pallone, for your 5 minutes of questions.
Thank you, Chairwoman Eshoo, and thanks to the witnesses for being with us. As we know, robust public health data plays a critical role in improving public health, and I wanted to start with Dr. Desalvo. You've worked firsthand both in the federal government and in industry on improving the collection and sharing of health data and know well how these investments can help improve health outcomes. For example, you played a leading role in implementation of the HITECH Act. In your testimony, you noted that CDC's data modernization initiative would benefit from the lessons of HITECH. So let me ask you, can you discuss, Dr., further what lessons learned from HITECH should be incorporated into the policies that we're considering to improve public health data collection, if you will?
Thank you, Congressman. It's an important opportunity for the country to, of course, recognize that we have created a digital infrastructure for healthcare. On the other hand, we now are about to embark on something like that for the public health infrastructure. And I do very much appreciate your comments that this could be boring to some people, but it's vitally important to the health of our communities. The specific areas where I think the country learned some lessons from the implementation of HITECH include first around data and standards. That means as we design the system going forward, what we should reflect on is that rather than allowing each information technology system to develop its own proprietary standards, its own special way of doing things. We should create an open opportunity where there's shared standards. There's already, we don't have to invent many of those. There's organizations called standards bodies that are already working with the CDC and public health officials around the country to identify and clarify which standards we can use as the foundation. So the building blocks all talk to each other, and we start with interoperability as the base case. The second is to make certain that we're thinking about the uses. What is the end that we have in mind? And as the committee is articulating in a number of the bills, equity has to be a part of how we design this system. Yes, we need the system to be able to identify infectious diseases and track on communicable disease for communities, but we also need to do that in a way that allows us to know where the resources need to be applied most. So building into that design, understanding of what are the data systems that have to tell the story around equity or around important public health challenges like maternal mortality. The last thing I would say is timing. We pushed out the funding for high tech and the system stood up. There was some training for workforce, but it delayed a little bit behind when systems were actually up and running. And I think what we all know is that it takes humans, it takes people to not only work those systems, but to interpret the data and the public health for the public's health and work with community organizations to put it to good use to make change on the ground. So we have to make certain that our workforce efforts are not only focused on COVID, but thinking more broadly about the infrastructure of public health and how to make that a durable, longstanding opportunity to make good use of the data to improve health and equity in communities.
Let me ask about resources, because, Congress has provided funding for public health data modernization, the CARES Act, a rescue plan, appropriations, but these were one-time investments. And you said that health departments need stable resources. So the Lift America Act, which was introduced by Energy and Commerce Democrats, has this core public health infrastructure program to help fund public health needs, such as facilities or equipment upgrades, workforce capacity, health info systems. Can you just comment on this program? In your view, what further steps should the federal government be taking to help improve public health data collection?
Well, Congressman, I first want to just say thank you to Congress for recognizing how important the issue is. The public health community, of which I'm a member, really is appreciative of the opportunity to meet the needs of the public. However, I think you're raising the important point that data doesn't happen in isolation. It requires a system, which means we not only need to have strong data systems, upgrades initially, but they have to be durable and sustainable so that the health departments can refresh the computers they have or refresh the IT security systems that they have over time. So it's an ongoing commitment that they would need to make sure they can meet the population's needs. They also need workforce. They need partnerships. They need basic infrastructure to keep the lights on every day. I mean, it's really would be hard to explain for many people in America how under-resourced and challenged many health departments in America are. I used to say when I was health commissioner, we do our work with 2 nickels and some friends, and we were really thankful for a lot of our friends. This is an opportunity in this pandemic, a learning moment, that we have a critical infrastructure that's been struggling to meet the needs of the population's health, is ready to do more, and I think through partnership, we certainly can think about investing in the whole system, not just the data systems. But I think we're on a good path as a country.
All right, thank you so much. Thank you, Madam Chair.
The gentleman yields back. The chair is now pleased to recognize the ranking member of the full committee, Ms. McMorris Rodgers. You have 5 minutes for your questions.
Thank you, Madam Chair. Dr. Saeed, we're talking a lot about the need for more data. I wanted to ask, based upon your experience working at a FQHC and at ChenMed, can you just further elaborate on the role of the doctor-patient relationship in addressing social determinants of health?
Thank you. It is so important for doctors to know about every emergency room visit. I was shocked during my time at the FQHC that half of all medical care in the city of Tampa was delivered in the emergency room setting. And then even further shocked when I joined ChenMed that in the United States, at least pre-COVID, half of all medical care was delivered in the emergency room setting. So doctors must know about every emergency room visit. They must know about things like when a patient doesn't fill their prescription refill. They must know about every referral when the patients are being referred to specialists. It's so important for doctors to also understand the costs of healthcare. Doctors should be more concerned about the medical complexity of their patient rather than the medical complexity of the charting, which unfortunately is what we see in the fee-for-service healthcare system.
Thank you. Dr. Batra, on Capitol Hill right now, there's a number of members, Democrats, that have been promoting the Medicare for All proposal. And the effect of Medicare for All would be to ban private health insurance plans, including Medicare Advantage plans. When you look at who's leading the way right now in addressing social determinants of health, it's really it's the private sector, as shown by the work that SCAN is doing. I wanted to ask, are there specific programs that you'd like to highlight as far as a success that could be implemented by employer or individual health insurance plans?
Absolutely. Thank you for giving me the opportunity. I think one of the programs that I highlighted, we call it the peer-to-peer program. And I think that has played a key role for us. I absolutely agree with Dr. Syed. Physicians are busy. Physicians really want to build that trust. But we also know that trust can be built with peers. So we have been utilizing our own members who engage with members in a way they can relate to, in the way they can empathize, in the way that they can understand around barriers that are big for this older adult population. Social isolation, 30% of our members tell us they feel lonely all the times or more than half the time. Similarly, around incontinence and falls. So our peer-to-peer program, which extends the reach of the physician team, has been able to do that. So I think that's a very key program. The other program I would quickly like to highlight is a community health worker program. If we truly want to address health outcomes in an equitable manner, we need to recruit people from the community that have the trust of the community, that can build on that trust of the community, that can not only help navigate this very complex healthcare system for our members, but also be able to connect them to community-based resources if they're not available, let's say, within even an MA plan in terms of benefits and programs. We have a very successful program we just published in one of our very well-reputed Journal of Geriatric Society. And that's exactly what that program does, is takes the physician's care plan and makes the care plan really happen where the patient wants it, in their home setting, in the community setting versus in the ER in the hospital.
Thank you. Thank you. Dr. Desalvo, the CDC has received over $1 billion from COVID relief packages to update, modernize public health infrastructure at the state, local, and federal level. I wanted to ask, what are the metrics that you would recommend that we use to determine whether or not those dollars are being spent wisely and driving results?
Congresswoman, thank you for the question. And I think we can learn a lot from what's already worked on the ground. I'll begin there. In states like Washington State, particularly a community like Spokane, that has a lot of historic work that it's done in partnership with community to address the public health. It was one of our Public Health 3.0 communities that I visited when I was in the administration and learned from. And what you learn from that is begin with the end in mind. And as a country, if we want to address inequities in top public health issues, there are bills before us today, for example, about maternal mortality and the disparities for Black women in particular. We could begin with what we call that INTECA use case, and then work backwards and say, then we need data that's going to inform actions at the community level to drive change. I will particularly call out, though, I think the importance of what was asked for in the Data Modernization Initiative by Congress, and that was for CDC to develop a strategic plan. And because that will be essential to have clarity about what needs to happen by when and by whom, those are the use cases. And then rather than just collecting data for data's sake, it must be done with the intention of improving the public's health going forward. So a strategic plan led by CDC, which is called for. And I think in addition, I would just call out Congressman Burgess's bill to think about what's already happening at HHS and this opportunity to do an assessment inside of the government of what are the levers that could be used. Once we understand from the data the challenges that need to be solved, how can we act on that to improve health equitably in community, address social determinants? Because there are many levers probably already underway, and it would be good to not be duplicative, but to make sure that we're being as efficient as possible because the public's counting on it.
Thank you all. I yield back.
It's a pleasure to recognize the gentlewoman from California, Ms. Matsui, for your 5 minutes questions.
Thank you very much, Madam Chair. And this is a terribly important hearing we have today with much legislation. You know, last week we examined the importance of increasing vaccinations to improve public health. And I'd ask the witnesses how we can help providers and public health systems modernize immunization and information systems to help support this goal. And may I say this, public health is so important. Public health involves the whole community. It involves people who don't have access easily to health systems. And I really feel I've got a huge health system in my district, 4 major hospital systems. I also have a great string of community health centers too. And I really have a wonderful public health center too. But I must say this, that we have not funded public health in the way we should be. And I think every time we get some sort of pandemic or some sort of crisis, we go back again and say, well, this is what we should have been doing. We can't do that any longer. So I really feel hearings like this are so important because, you know, we look at the social determinants data and that exacerbates health disparities. And the bills today we're examining can provide a range of solutions to capture the central data that is important to ensure that people don't fall through the cracks as they did this time, as we promote health and mitigate disparities beyond healthcare, including access to healthy food, education, housing, and transportation. So I'm really interested in exploring how we can strengthen public health reporting by leveraging both clinical and public health data. And a lot of this data is not just in the health arena either. It's in schools and education systems. It's in, just as somebody said before, just listening to people, encouraging conversation. Those kinds of data is really important to actually understand fully what is happening. Ms. Bauer, you highlighted the need for robust data collection and reporting systems at the local and state levels. And this on-the-ground expertise is really important. So as we build out our health data utility infrastructure, how can we coordinate more of the state level health information exchanges and other clinical data sources? I know there's a lot of conversation that goes on with our community health centers and the public health area, but how can we facilitate this even more so that it goes up so that we can actually capture the data and understand what's happening throughout not only the state itself, but throughout the regions? Ms. Bauer?
Thank you, Congresswoman, for the question. One of the things I've learned in my experience in the public service is that there are some of the most important thinkers and subject matter experts across the board in government. We have some of the smartest thinkers, but we need to invest in the skills of subject matter experts to actually use data to solve hard problems. So there is one part where we need to start investing in the capacity of people who are actually charged with leading programs on how they can use data. The health information exchanges are also incredibly rich resources that exist that have great data and great data skills, but there is a disconnect between the exchanges and those people on the ground who are responsible for delivering programs. And so we need to start thinking about how can we build the capacity so that we're scoping our problems, that we're thinking about our problems in a way that elicit the right kinds of data responses, and that we have the skills to actually take that data and apply it to solutioning.
Okay, well, thank you. Dr. Desalvo, we're talking about structural racism here. It's a public health crisis, and I thank you for drawing attention to this in your testimony. This was a huge issue after Hurricane Katrina, and 15 years later, what has the COVID pandemic revealed about the structural racism in the digital infrastructure?
Thank you for raising the issue. It's been such an important conversation in the pandemic, but as you say, it's not a new conversation in many circles. We saw it very clearly after Hurricane Katrina. I saw it personally as I was on the streets delivering care to people that where you live matters so much. It was described by another witness, a 25-year gap in life expectancy in New Orleans, a whole generation based upon where people live. And where people live is not just about a choice, it's also about structural systems that cause redlining and other factors that make a difference in the access you have to food and education and economic opportunity. It's really motivated many of us in public health to focus on this as a public health issue. In fact, in a recent National Academy of Medicine report, I had the chance to co-author with Bob Hughes from Missouri. We talked specifically about how coming out of the pandemic, equity and racism will have to be priorities for public health, and that the data systems that are built will have to be capable of providing information not only about individuals and how their health is different, predicated on things like the color of their skin or race and ethnicity, but also what are the structural systems supporting them? What are the school food programs? What is the access to sidewalks so kids can walk to school? So it's a double layer system, not just that looks at people, but also at the context in which they live.
Well, thank you very much. I've gone way over my time, and thank you very much for testimony. And thank you, Madam Chair. I yield back.
The gentlewoman yields back. Pleasure to recognize the gentleman from Michigan, Mr. Upton, for your 5 minutes of questions.
Well, thank you, Madam Chair. Thanks for this hearing today. The ability to access and use information is certainly critical to many aspects of healthcare and health system operations, and the further embrace of real-world data and evidence, including SDOH data, can all help improve the facets on healthcare. 21st Century Cures Act included provisions to improve data sharing through reforms to the statute created by the HITECH Act that established the Office of the National Coordinator, ONC. However, as we know, this issue is bigger than ONC. How we use the data today is negatively impacted by a number of things, including how we regulate data use or how capable the agencies of HHS are using the data well. Representative DeGette and I released a discussion draft earlier this week that we're calling Cures 2.0 to help solve some of the issues that we're discussing. I'd like to focus on two of those provisions. Ms. Blauer, Section 304 of Cures 2.0, entitled Increasing Use of RWE, builds on FDA's efforts by requiring HHS to outline approaches to maximize and expand the use of RWE and establish a task force to develop recommendations on ways to encourage patients to engage in RWE data generation. So as we consider ways to improve data access and use for many in health, how important is the patient participation in data access for the FDA or other healthcare operations?
Thank you, sir, for your question. So I want to start by saying that I think a lot about resident engagement and patient engagement in data across the board. I think we need to be incredibly comprehensive as we think about how we reflect the realities of life in the way that we collect data, and patient information is at the center of that consideration. But we have to obviously make sure that we include all of the protections and the privacy and the advocacy that's required to keep people's personal information safe and make sure that they are informed significantly in order for the safe collection of that qualitative contribution to data collection, but also to really understand why it's important to have individual information as part of a consideration for data collection.
Thank you. Dr. Walker and Desalvo, my staff over the years has communicated with CMS and other agencies about the current capabilities of their computer systems. Generally speaking, the feedback has not been terrific. One provision of Cures 2.0 would begin the process of Congress working with HHS to update CMS and other computer systems with a goal of helping these agencies use the data better. So as we consider the bills before us today, I'm curious to your thoughts on whether improving CMS data capabilities through modern computing approaches can help support our goals.
Thank you. I'll go first, and really appreciate the opportunity. From a state perspective, we certainly would appreciate having additional support for CMS to update systems to allow for us to work together as states try to engage and leverage data that's available. I think as we learn more about the impacts of social determinants of health, there are models that can test how we support payment strategies and delivery system innovation. For example, CMMI's Integrated Care for Kids model and the maternal opioid use model, as well as other programs like Medicaid waivers, really allow you to look at how you're investing in the earliest years of life. But the challenge is understanding what's working, and you need data to do that programmatic evaluation and assessment. We know at McMorris, as we try to deploy value-based services and new types of care delivery, we absolutely need opportunities to work with CMS to develop demonstration models, to invest in the data, and really figure out how to implement value-based payment.
I will just maybe add a related issue, if I could, Congressman, which is to, first of all, I'm not an expert in the CMS data systems, though my appreciation is that they are in need of some upgrade. And I think as Dr. Odom Walker is describing, that opportunity there has to do with making sure that we can meet the needs of the population's health using data that can support value-based care models or global health models. But I particularly wanted to call out that in Cures 1, there was a push towards open APIs, FHIR-based systems, which I know you and your team are familiar with. Those same models can be applied to public health. And as we think about modernizing the public health data infrastructure, and because of 21st Century Cures, there's been a movement in the field of public health and the digital world to create that kind of an interoperable system so we don't repeat any of the mistakes the country made with high tech. So thank you for that direction and visioning.
Gentleman's time has expired. And thank him. Pleasure to recognize the gentlewoman from Florida, Ms. Castor, for your 5 minutes. And I want to remind members that questions are being, those that are, I'm sorry, we're calling on members in the order of subcommittee seniority. Okay, just as a reminder. Ms. Castor, you're on.
Great, thank you very much, Madam Chair. Thank you for calling this very important hearing. And thank you for including my bill with Congresswoman Underwood, the Ensuring Transparent, Honest Information on COVID Act, the ETHIC Act. Colleagues, this committee, Democrats and Republicans, have really shined the light on the lack of transparency and the consistency around COVID-19 data during the pandemic. I think there are three main issues. One, many local communities and states did not have the modern data reporting systems in place. Two, there was a troubling pattern in a number of places of withholding COVID-19 data, censoring of data, whether it's nursing home infections and deaths or overall mortality rates or testing. Very serious issues there. And then three, of course, we don't have the demographic data we need on health disparities, and we have to do better on that. Communities, businesses, public health experts need this consistent and transparent health information to help keep families safe and to implement effective measures and do it efficiently. So through the bipartisan, as Chairman Pallone said, through the bipartisan emergency relief packages, this committee really helped direct huge new investments to update data reporting at the CDC. But we're going to need to provide additional direction. And in addition to the bills that get to it through standards, which is very important, the ETHIC Act also will do this through transparency in data reporting. One, it will require states, local communities, tribal and territorial governments to report COVID-19 data, including demographic information, to the CDC and to make sure that it is all reported to the public. And then two, we need to tap the expertise of the National Academies of Sciences, Engineering, and Medicine to review the current system and provide us with additional recommendations on public health, data infrastructure, and reporting. For Ms. Blauer, thank you so much for your long time and very important work to improve health outcomes using data, but especially for your work and that of Johns Hopkins, the Coronavirus Resource Center over the last year. In your testimony, you say that consistency across states is going to be vitally important. You highlight the Ethics Act. Thank you very much. But can you also talk about what do you see that we need to do to ensure dependable, transparent data for the public, for communities, for businesses going forward? What else do we need to be doing?
Thank you, Congresswoman, for the question. I can say with great authority that there is a hunger at the state and local levels for standards, for this common language that actually can help guide the way that we collect and think about data across our states and our cities. We had, over the course of our managing the Coronavirus Resource Center, daily calls with mayors, with governors, with people from local communities, from health departments that were seeking advice on how they should collect this data, how they should express this data to the public, how they should be thinking about letting this data support their decision making. And they were searching for support and validation of their approaches. So again, while the systems that collected this data were often shoestring operations in some cases, started with manual collections that did mature over time, I think the reality is that these organizations across the board in state and local communities were really seeking that kind of high level validation that what they were collecting and how they were using this data was the right path forward. And they also wanted to be able to look at their neighbors and say, I see that you're having better experience in managing this part of the pandemic. I want to learn from you. And in the absence of those standards and that common language, it became very difficult to do apples to apples comparison across the geographies. And so the role of federal government here could really be, let's create that common language, let's provide those standards, and then let's provide the support for the state and local communities who are going to be navigating these health challenges in a way that they can learn from each other, they can learn from their wins, they can learn from their failures, but then they can also think really critically about how they're applying data to the policy levers that have been so critical to the way we've navigated the pandemic. Thank you again.
Thank you very much, and I yield back.
Gentlewoman yields back. Pleasure to recognize the gentleman from Virginia, Mr. Griffith.
Thank you very much, Madam Chair. I'm very happy to follow Congresswoman Castor talking about ensuring transparent, honest information on COVID-19. Ms. Desalvo, it is being reported that there are financial ties between Google and EcoHealth Alliance, a company that was collaborating with the Wuhan Institute of Virology to conduct bat, coronavirus, and other virus research. As donors to EcoHealth Alliance, do you support its lack of cooperation with my request and the request of other members of this committee as we seek information about the origins of COVID-19?
I appreciate the question, Congressman. I don't have all the details of that report, but I believe the reporting has been inaccurate. The one-off grants that were received by that researcher were years ago and predate the pandemic. So my appreciation is they're not related.
Well, and they certainly predate the pandemic as far as the base research, but the data indicates that there was a 2010 study on bat flaviviruses that was listed as being supported by Google. There's also a 2014 study on if I'm pronouncing it correct, Henipavirus, which infects terrapid fruit bats and microbats, and that was on the spillover. And then a 2018 EcoHealth Alliance paper entitled Serologic and Behavioral Risk Survey of Workers with Wildlife Contact in China, that was made possible with the contributions of Google. So it clearly predates the coronavirus outbreak, but this research has been going on for over a decade. And the real question is, does Google support or condemn EcoHealth Alliance that they donate to? Do they support or condemn the stonewalling of members of Congress who are trying to get information about what happened with COVID-19 and what the origins really are, whether it was a wet market situation or was it a lab leak?
With respect to to this particular investigator or set of investigators, as I said, I haven't seen the reports and I'm not intimately familiar with the work. What I can commit to you is that we will work with you in your office and come back with answers that you may have, and see that we have the right people who have more intimate knowledge of the situation.
And I appreciate that, and I would also appreciate any conversations, emails, et cetera, that Google may have had from EcoHealth Alliance that may have indicated to them information about COVID-19 since you all were involved in earlier studies related to bat viruses that Mr. Dashak of EcoHealth Alliance was one of the authors of saying that this was clearly coming from wet markets and from bats, and you all were involved in that. Any conversations you all might have had in 2019, 2020, or 2021 regarding that, if you could get me that information, that would be greatly appreciated. And can you commit to working with us to get that information?
Certainly commit to working with you all, and I'll have the right people follow up with your office.
I appreciate that greatly. It's important that as we talk about having an honest and transparent discussion about these items, that we move forward working together. And is Google prepared, because it has been criticized in the past for failing to demonstrate a commitment to fostering open debate on scientific issues such as this, is Google prepared to commit to such an open debate?
I'll tell you that, Congressman, I very much appreciate you asking that, because as a physician, the debate about the medical treatments and origins and even the diagnosis of COVID has been a rich and complex environment for the past year and a half, and not only for the medical community and the public health community, but the community at large has been involved in trying to understand as we learn on the journey what works, what doesn't work, how should we be protecting people in communities, how should we treat our patients in the hospital or at home. So as that information has evolved, we've relied on trusted authorities like the CDC or the World Health Organization outside of the US to provide authoritative content, so we can lean on the group of scientists that build consensus statements from those authoritative groups. And then we use that to inform policies that we apply to information, not only to raise up important quality information that we want people to have, people to protect themselves and their families, but
Yes,
also to bring down harmful misinformation.
And I appreciate that, and I think we should go forward working together, and I hope that Google will have an open policy on scientific discussion, because the EcoHealth president has recently been taken off of or left the WHO study, and it's now becoming clear that they are somehow involved. We don't know exactly how, because they're stonewalling us, and all we want here are answers for the American people. I yield back.
The gentleman yields back. A pleasure to recognize the gentleman from Vermont, Mr. Welch, for his 5 minutes of questions.
Thank you very much. I want to thank all the witnesses for being here, and I want to bring up Congresswoman Bustos's Social Determinants Accelerator Act, and I'm a co-sponsor. And it's really important to Vermont. In the Vermont Housing Needs Assessment in 2020 showed that more than 19,000 Vermont households face housing quality issues. It includes homes with coal or limited heating sources, 40-year-old mobile homes, incomplete plumbing, and so on. And unfortunately, too many Vermonters do live in these conditions. Dr. Walker, you mentioned the Social Determinants Accelerator Act in your testimony. And the bill, as you know, would create a program at CMS to provide grants to state and local governments to develop plans to combat social determinants of health that are resulting in negative health outcomes. Are you aware of any cities or states who've developed a strong model to improve housing and health outcomes at the same time?
Thank you, Congressman. I think there are a variety of examples that are critically important, not only around housing, but also around non-medical transportation, home-delivered meals, and educational services. And some states have incorporated waivers into their Medicaid program. I think a few examples exist, including North Carolina, where they are incorporating this into their value-based payment. Maryland is certainly implementing a program to support individuals with developmental disabilities. And there are others, including Minnesota's waiver that looks at the provision of housing stabilization for individuals who are at risk for homelessness. I think using these examples and innovations are helpful. They also allow us to invest in families, which have long-term impacts on the health and wellness and mental health and well-being of children and adolescents. And so having these examples is helpful, but encouraging it across our nation could be a tremendous health impact.
Thank you, Dr. Walker. And Dr. Desalvo, you also discussed the need to address social determinants of health, housing being one of them. How can investment in an updated health data system, including the use of qualitative data, which you mentioned, help improve public health and build up our community suffering from systemic health inequalities?
Thank you, Congressman, for the question. And I will answer it. I do want to first give a shout out to Vermont, who's done some great work, particularly for populations with substance use disorder and understanding how to blend and braid resources to address social determinants of health, including housing. Housing being, for people, probably the most important social determinant of health. Saw that firsthand after Katrina, and we see that every day in communities. So I also appreciate you raising a really important foundational structure for individuals. Two particular points. One is that data has to be timely, actionable, and granular. It has to be not only quantitative, because you need anonymous population-level information that you can map to direct intervention, but you also need the voice of community. Some of the bills today include that concept that there have to be community advisory voice, particularly those bills, the bill about maternal child health. But that's true in every context, and that can be done manually, if you will, human to human, and that's important. It can be augmented by additional data sources. I mentioned information that Google's made available to public health on the open repository, including search symptoms trends. Again, this is anonymized data that's at the population level that could be useful to augment the other important data that public health needs to take action. Final point, these bills, many of them speak to this idea of community collaboration and partnership. I think you'll find threads throughout many of the successful projects in communities that it is really about everyone coming together to create the conditions for health, not any one sector alone. So public health with business, faith-based, and others. I'll just give for your information and for your staff, particularly the NASDO, the National Alliance for the Social Determinants of Health, has a report on their website that talks about some great examples across the country and a playbook for how communities can do this, including what the data needs might be.
Thank you very much. Madam Chair, I yield back.
Gentleman yields back. The chair is now pleased to recognize Dr. Buchan from Indiana for your 5 minutes of questions.
Thank you, Madam Chairwoman, and thank you for having this hearing. This is really important. Social determinants of health are critical in today's healthcare system to improving outcomes and better understanding why social situations that people in our society are in actually have a substantial effect on their ability to lead healthy lives and to get good outcomes. But it's a very complicated subject. I've worked on a lot on maternal mortality and maternal health. We've had testimony from physicians from Parkland Hospital in Dallas, for example, which that is a public hospital for the underserved, and many of their patients are on Medicaid. And their health outcomes were outstanding as it relates to maternal health. And then we heard testimony from other areas of the country that also service underprivileged and primarily Medicaid patients where their data wasn't quite as good. So we really need to know why this is and why that, and I think part of that is because Parkland Hospital has data-driven protocols to how they take care of patients, at least in the maternal health, but this is also across our healthcare system. It's all about innovation, I think, in healthcare. Innovation and better collected data help promote a more value-based system that, in my view, helps lead to better outcomes because we are able to determine why the outcomes are poor in one area that serves a similar population, but outstanding in another area of our society. One area I want to focus on was the provider's role in gathering and collecting of data. As we know, doctor burnout is at an all-time high. Most of the time, the main reason, in my view, for this is due to the burdensome paperwork and duplicative administrative tasks that a lot of physicians don't feel they signed up for. They want to take care of people. All of this has doctors spending more time doing paperwork and less time with their patients. While I think data is important and should be incentivized, I'm cautious not to put more of a burden on doctors and other providers who already need more time with their patients. In that vein, Dr. Syed, it is my understanding that there are existing ICD-10 codes for social determinants of health that most doctors aren't collecting at the moment. In order to properly advance social determinants of health policies, someone will have to be responsible for reporting the data collected. In your experience, who is responsible for collecting the data needed for better social determinants of health, and whose responsibility would it be if some of these bills considered today would become law?
Thank you. In my past life in the FQHC world, it was in the fee-for-service system. It wasn't in a value-based system like I'm currently in with Medicare Advantage. So I was forced to focus on sick care. I've always felt like I was 2 steps behind. I remember I was always reacting to problems that were already out of control. See, in the Medicare Advantage environment, practicing preventive medicine keeps all of us, not only the doctors, the nurses, all of our care team members, many steps ahead. And that's when you're able to notice the small changes before they really become the big ones. So it should be the primary care doctor being at the center of the care delivery system.
Yeah, well, I appreciate that, and I think, that does add some administrative burden. But I do agree that there has to be someone, the primary care doctor, is kind of the captain of the ship. And so I just want to make sure whatever we do doesn't unnecessarily burden providers. And so I want to talk a little bit more about your experience in Medicare Advantage. Why do you think it is more of that more of the federal government and state governments are so hesitant to embrace the existing approach that gives plans and providers a risk-adjusted amount of money that lets them decide which social determinant interventions need to take place without adding more burden-inducing reporting and box checking? Because what you just described sounds better to me than maybe the system that you had experience with before.
Well, sure. I mean, all of us got into medicine to help people. None of us thought that we'd be getting into healthcare and spend hours every day focused about the documentation required for reimbursement. So what I would like to see is really more education about Medicare Advantage, because our current system is based on sick care rather than primary care. You see, with the Medicare Advantage model, it puts the primary care doctors at the very center of the entire care delivery system. You see, then the doctor has the time to look into the causes of the causes. And then you get to know the patients better than any other random doctor. I think what you mentioned about the choice, patients should be able to go to any doctor they want whenever they want. And it sounds great in theory, but when your health is on the line, you really want a referral from the doctor who knows you the best, the one that you trust the most. And with the Medicare Advantage world, I just wanted to say that it gives me the time to establish the trust with my patients and make the same referrals I would for my mom or my dad.
Thank you for that information, and I yield back.
Thank you. Thank you very much, Doctor. A pleasure to recognize the gentleman from Oregon, Mr. Schrader, for your 5 minutes of questions.
Thank you very much, Madam Chair. I appreciate it. I, too, am a supporter and co-sponsor of Ms. Bustos' bill on the Social Determinants Accelerator Act. And I think it's very important to have that coordination. We've heard here today from our witnesses and others that without that coordination, it's very difficult to get things done. And in my home state of Oregon, one of the big projects that's worked extremely well is our coordinated care organizations to deliver Medicaid or Oregon health plan benefits for a lot of folks. And they're grown up from the ground up. It's not something that is put top down from Washington, D.C., and actually has those social determinants worked on by the community organizations that know that community best. And I think that's what Dr. Bashan was alluding to, and I would agree with him. We shouldn't be managing, counting different things. It should be about providing quality health care. Dr. Syed, I think, hit the nail on the head in his comments and responses there. I think it's just so important to coordinate this sort of thing. Dr. Blower, with the interagency council suggested in the Bustos bill, how do you see that getting out best practices like we have in Oregon to folks around the country?
Thank you, Congressman, for the question. I think the most important thing is that oftentimes, particularly when we talk about data or IT infrastructure, our gut is to put data and IT folks on these interagency committees. And what we need are subject matter experts who are deeply knowledgeable about the impacts of program decision-making and the realities of program delivery on the ground. So I think first and foremost, you need to make sure that they're staffed with people who have deep programmatic expertise and who understand what the objectives of the work are, and understand how they can leverage tools and technology to actually do the delivery of the services and to support the work of the committee. So subject matter expertise, absolutely. And then prioritization. We need leadership that actually can lead with prioritization. We will end up in a boil the ocean moment if we don't have clear goals that are articulated and measurable, and that we can focus our work collectively on. There is a lot of work to be done, and without that kind of direction that will allow for us to have those sort of clear priorities outlined, we're going to be in a situation where we're going to get overwhelmed very quickly. And governance allows you to create prioritization with the inputs of that subject matter expertise.
Very good. Thank you. Thank you. Dr. Syed, you talked about being fully capitated, that makes a difference. What's your definition of fully capitated to make Medicare Advantage system work in your eyes?
It's a model of, especially with primary care, where the doctors are not concerned about generating revenue by billing. Being fully capitated, we take on the full responsibility of the total health of the patient. And so it gives us the flexibility to treat seniors with multiple chronic medical issues according to their actual individual situations.
I agree with that, and I think that points to Dr. Bichon's concern about it shouldn't be the MD that has to worry about counting all the widgets and worrying about reimbursement. If you have a coordinated care group like we have in Oregon, that organization deals with that and decides along with the physicians, with the hospitals, with the mental health providers, with the pharmacies about who's getting what amount of money based on those local needs. I don't see why we don't even just transition to that. Fee-for-service is so outmoded. I have remote parts of my district, very rural parts, that are part of coordinated care districts that provide much better health service tailored to those individuals. Dr. Walker, I appreciate you mentioning the value-based payments, as we just discussed here. What policy should we be pursuing to foster growth in that arena? We're actually trying to do that, Mr. Guthrie, Mr. Mullen, and I, with regard to pharmaceuticals, but I think it obviously applies here in terms of just care delivery. What should we be doing to foster growth in that area?
Thank you, Congressman, for the question. I think it's essential, as some of the bills indicate, that we need to incorporate incentives, expertise, and make sure that states have the bandwidth to move forward with value-based payment. That often can start with Medicaid, but go beyond once you learn the lessons. Medicare Advantage is fully taking on this value-based payment role, but it does take a bit of guidance. And the Caring for Social Determinants Act does include a recommendation to include that updated guidance to allow for innovations like the CCOs to flourish in other places. But it does take leadership, it takes alignment, and it takes the right expertise. I think that's where having data to look at the alignment of incentives can be incredibly helpful too.
Very good. Thank you. Thank you all for your work, and I yield back, Madam Chair.
Gentleman yields back. It's a pleasure for the chair to recognize the gentleman from Oklahoma, Mr. Mullen, for your 5 minutes of questions.
Madam Chair, thank you so much, and thank you for putting this hearing together. Dr. Desalvo, I hope I'm saying that right. If I'm not, please correct me. Based on your experience in public as a public official, can you kind of speak to the importance of aligning federal programs to address the social determinants of health?
Thank you, Congressman. On behalf of my husband's family, I'll say it's Desalvo.
Desalvo, thank you.
Congressman, in Oklahoma, you have an incredible example of how a group of primary care clinicians came together to create an information exchange. This is My Healthy Data, and built a global population health model like we were just describing to really allow the docs to care about the patients, and then the data gets collected around them and the patients, but that data now tells a story of a community's health as well. So it's informing public health action. It's a wonderful example of how federal action to spur the innovation and models of primary care, of health information exchange, can then also not only improve the care of patients, but begin to tell a story or improve the care of populations. That group, for example, has done incredible work in COVID, creating dashboards that can help the community understand. I believe you had the opportunity to see some of those. So I think it's a wonderful also example of how the foundation of electronic health record information, primarily for the use of individuals when anonymized, can be useful to help understand the health of a whole community. And it's the kind of innovation that we could spur scale across the country and shorten the timeline to being able to do good work. What's great about that particular effort, by the way, is that it's transparent. The docs have a lot of say in the data and how it's used, but also it helps to build a virtuous cycle of improving the quality of care and, as I said, improving the health of the population.
Are there any examples, like in your experience, that you can use to kind of highlight on how this has been working?
Definitely. I think in addition to the example in My Healthy Data, there's a couple of states that have been leaders in this area of using existing data that was built on a foundation, often from a federal program, and then gets expanded. I'll call out another primary care example, one called Macroscope, which was built in New York City by the Public Health Department using data from their primary care clinics. Similar idea. We already have data. Let's not repeat the collection. Let's be efficient. Let's anonymize it and use it as a way to understand what are the rates of diabetes and high blood pressure in our community. And it's a pretty timely, actionable, granular set of data that public health now can use to target interventions, to address inequities, to address the social determinants of health. I could go on in a long list, Congressman, but I think what I would love for the committee and for others to know is innovation between public-private partnerships, community-led on the ground, is happening all over America. I visited so many in the course of my career. We've written about them in Public Health 3.0 and the National Academy of Medicine report I referred to earlier that we just recently put out on public health. So we have a sense of what works, and we have a sense also of what works from the data. Now what we need to do is make sure that we've got strategy and prioritization and direction, but also fill gaps in the data layers and make sure that that data layer is interoperable and can help us address inequities.
Well, that actually leads me right into my next question, which was going to be, what can Congress do to kind of help it easier for private sector and nonprofits to work together on various funding streams to coordinate in this way?
This is an interesting and complex area. One of the calls that comes from community often is when they create collaborations, they want to not only share governance and data, but they want to be able to pool or share resources. And there's more latitude probably than many communities realize. Communities like Oregon or Rhode Island, Vermont have found ways to blend and braid funding to support particularly low-income populations and address social determinants. But I'll tell you what, I've done that on the other end when I was health commissioner, addressing needs of youth and violence. It's very hard to blend and braid funds sometimes. So I think some of the consideration in the bills, or for example, these interagency councils, could be to catalog or understand what are the flexibilities that communities could use to not only blend and braid the public sector dollars, but how can the private sector contribute in a way that's, again, transparent, shared governance, and shared accountability for the outcomes.
Doctor, thank you so much. And Madam Chair, I'll yield back the remainder of my time. I want to thank you again for putting this together, though. This is vitally important to a lot of our communities, especially the rural parts of the country.
It is, and you asked wonderful questions. Thank you. The gentleman yields back. The chair now has the pleasure of recognizing Mr. Cardenas from California for your 5 minutes of questions.
Thank you, Madam Chairwoman, and also thank you, Ranking Member Guthrie, for having this very, very important hearing. And I always appreciate all of our experts coming to educate us policymakers so that we make sure that we can do the best job we can to serve our country. And we're up here on 30,000 foot level, and you're there on the ground. So thank you so much for all of your expertise and your wonderful insight. Also, Chair and Ranking Member, thank you so much for putting HR 3969 on the agenda today as well, carrying that bill with Representative Curtis, and appreciate it being in the hearing today. This bill would include spending on activities related to social determinants of health and the calculation of private health insurance plans and medical loss ratio. In introducing this legislation, we recognize that social determinants of health, like reliable transportation, availability of nutritious food, safe housing, are all primary drivers of health outcomes. And to achieve health justice and equity for all, we must be more intentional about how we address their impact in all parts of our healthcare ecosystem. Dr. Batra, in your testimony, you discussed the Senior Care Action Network, SCAN, the approach to addressing social determinants of health. Could you please talk about the impact of this approach on members in your network?
Absolutely. I think we started off by making sure we collect data the way the members would want their data to be reported, how they identified. So for us, having the data around race and language was very important. Similarly, we have collected years worth of data on our members around their social needs, so transportation, food insecurity, loneliness, in-home caregiving and support, hearing dysfunction. And we have really used that data to help identify members' needs and connect them to the right benefits and the right programs. So for example, 70% of our population suffers from hearing dysfunction, which, as you know, can interfere with so many different things, lead to isolation, lead to loneliness, also lead to poor health outcomes. We have hearing aids as one of our supplemental benefits. So we try and engage with members and connect them to that. Similarly, a good example during the pandemic was around transportation. People wanted to get the vaccine, did not have caregivers around them, had a son, daughter-in-law live in a different state. We were able to arrange those rights for them. The other unique thing that we did during the pandemic and vaccination was, as people were getting vaccinated in doctors' offices and convention centers and pharmacies, we had folks who were homebound and could not leave their homes. We were able to get the vaccine to their home, not only for the members, but also the caregivers, because they were the ones taking care of their loved one who happened to be with us. So those are some of the high-level benefits that we have used. We have done studies that show that if you have transportation insecurity or food insecurity, you're going to have worse outcome on your diabetes. And so we are consistently looking at ways in engaging our population with either be a program or a benefit and ensuring them they have it so as to fulfill their needs.
Thank you. And can you give us at least one example about what we can do going forward as Congress? What kind of effort can Congress afford you out there in the community?
Absolutely. So as we, first and foremost, I want to really thank the Congress for providing us the flexible benefit flexibility. We were able to design all these newer benefits to meet the social needs of the population that started in 2019. So the benefits that I alluded to, in-home caregiving, meals after discharge, care coordination support, and occupational therapist. However, these are based on still your medical needs. So you have to have a qualifying diagnosis, like you have diabetes or you have heart disease or end-stage renal disease. If we truly believe there should be equity for all, if we truly believe that social needs are the first and foremost drivers of health, then perhaps we should be allowed to kind of design some of the benefits based on the social needs of the population. So that's one area that comes to my mind. And the second area is, during the pandemic, as we were scrambling, we did about 100,000 social outreach calls to check in on members. We actually have a benefit that helps people sign up so they can, somebody be their help desk so they can have that telehealth visit with their doctors. We noticed there's zip codes with high social vulnerability index where people did not have access to Wi-Fi and iPads and technology. And for those, the telephonic assistance was really, really important. In order to extend the reach of the primary care physicians, that's the other area we would really want Congress's help in keeping telephone as one of the ways of engaging with the member, engaging with the patients and helping them.
Thank you, Dr. Batra. And it's very rare for us members of Congress to get a thank you. So thank you for slipping that thank you in there. And just wanted to say how focused many of us are of making sure that we modernize our public health data infrastructure and outreach, because those are some of the major lessons that we learned during this pandemic. My time has expired. Madam Chair, thank you so much for having this hearing. I yield back.
Most welcome. Pleasure to recognize one of the doctors on our subcommittee, and we have, I think, 5. We're blessed with, I think, 5 doctors. Dr. Dunn from Florida. You're recognized for your 5 minutes of questions.
Thank you very much, Madam Chair, and also thank you, Ranking Member Guthrie, for hosting this hearing today to examine the ways that data can affect public health. You know, over the course of the COVID-19 pandemic, Congress spent hundreds of millions of dollars to support data collection and data infrastructure modernization. And whether those dollars were used for centralized CDC data assimilation or grants to states and local governments for data collection, the money is already out the door. And we need to evaluate how these funds are being used, I think, before we consider another slate of new bills to advance more data collection as it relates to improving the care of the health of American people. High-quality health care starts with the doctor-patient relationship. Dr. Syed said that in his testimony. And it should consider the individual needs of patients. You can't just crunch data and pigeonhole people without taking a holistic approach to the patient. We also can't rely on bureaucrats in Washington to make decisions about health care for our individual patients. People simply cannot be reduced to a set of data points, no matter how voluminous they are. I also want to associate myself with the remarks of my colleague, Dr. Burgess, when thinking about requiring more and more data collection. The potential that that information will be shared across other entities requires that we have reliably strong safeguards in place to ensure patient data remains private and that HIPAA protections are in fact upheld. And with that, I'd like to ask Dr. Syed a question. I appreciated reading your testimony, hearing your views on creating more value in the healthcare system. You touched on the coordination of care and strong doctor-patient relationship and matching the resources to the patient's needs in order to drive improved outcomes. It seems to be you're an advocate for the flexibilities that the Medicare Advantage system allows in terms of value. And you cited many examples in your testimony. Now, let me say I share those views with you. From your perspective, is increased data collection in the primary care setting the sine qua non to improved health outcomes? And so a lot of these proposals are talking about involving significant additional reporting requirements and gathering a great deal of data. And I know personally that doctors are already suffering a fair amount of burnout and stress over administrative burdens. Dr. Bouchon made allusion to that in his questions. What's your perspective on that question, sir?
Thank you very much. With regards to data and collecting more data to improve patient health, there's some things that I feel as a doctor I could speak to. When we're talking about improving health, I'm thinking about if we know medications are critical to improving health, we should not let patients walk out the door without their medications. Like if we know that heart disease is the #1 killer in the country, then we should have cardiologists working hand in hand with the primary care doctors. And if we know that a major part of improving health is overcoming the barriers to the care, then we should have social workers integrated into the care teams. I think rather than collecting more data, we should kind of relook at how care delivery is happening right now in the country. And to what someone else said earlier today, if we know that doctors are getting burnt out from doing all the non-doctor work, we should have the care teams take over all the administrative duties and just let the doctors be doctors.
So let me say I like that answer very, very much. Certainly would have made my life a little easier the last 10 or 15 years. You shared a story about uncontrolled diabetes, I believe, in your father. And I think that you would agree that data helps with that, but also it's that personal time you spend with them. Say, let's work with each other and let's do the right things. In other words, it's really a relation. It's that doctor-patient relationship. Would you agree with that?
Absolutely. I think about, yes, absolutely. I think about a patient I had with morbid obesity. And because of the flexibility with the Medicare Advantage program, I was able to see him as often as I needed to see him. And I was more of a health coach than I was a doctor for him. And I was able, in 6 months, I was able to see him 7 times and get his weight down from 250 to 220 pounds. In my previous job, I couldn't even see him more than twice a year. So that's just a difference. It's a completely different approach towards
Certainly,
care.
our time's about over here. I certainly appreciate that. I agree with it. In Florida, we experimented with a sort of a hybrid Medicare Advantage, Medicare fee for schedule. So when the specialists and the primary care working together. But I thank you for your comments. I thank the witnesses, and I thank our chair and ranking member. And I yield back.
The gentleman yields back. Pleasure to recognize the gentleman from Maryland, Mr. Sarbanes. You have 5 minutes to question. Great to see you.
Yeah, thank you, Madam Chair. I want to thank all witnesses for being here for this important hearing. I deeply share the concerns of my constituents and those that are hearing today about the impacts that the coronavirus has had on communities of color. I believe Congress should use every available tool to create an equitable recovery, as well as address the root causes that have created health disparities for years. For too long, the federal government has failed to adequately recognize and address structural racism as the public health crisis that it is. Black and brown communities have been denied access to quality, affordable health care, have faced barriers to securing safe, quality, affordable housing, and have suffered the consequences of environmental racism for generations. The COVID-19 pandemic, as we know, unveiled and exacerbated longstanding racial disparities in health outcomes. It's time we recognize and treat structural racism and police brutality through a public health lens when we can. Under the Biden administration, the CDC has begun this work by declaring racism a public health threat and committing to addressing racism in the context of health equity. I commend the CDC for this step, and we in Congress are committed to assisting in the effort. One way to do that is by passing the bills we are discussing today, including the Anti-Racism in Public Health Act and the Social Determinants Accelerator Act. The Anti-Racism in Public Health Act is a critical bill introduced by my colleagues, Representative Ayanna Presley and Barbara Lee. This bill would expand federal research and investment into the public health impacts of structural racism, require the federal government to proactively develop anti-racist health policy, and take a public health approach to combating police violence. Among other things, it would create a national center for anti-racism at the CDC, which would award grants to study the health impacts of structural racism. Dr. Walker, I wanted to turn to you to elaborate on this a little bit. What is the significance of the CDC recognizing racism as a public health issue?
Well, there is clear evidence that racism creates a public health threat, and it creates not only immediate stressors, but also long-term health effects that we need to combat. But many of those factors are ones that we've talked about as social indications around housing, around transportation, around can you just get access to the care that you need. We know for children and adolescents, some of those factors are around mental health access and needs. And resources in schools. And so having the ability to really provide federal resources to make sure that states and local communities can invest in these social factors and increase the ability to address it at a community need based on those priorities and those areas of local context are important for us to be able to incentivize health and well-being at the most local level.
Thank you very much. And I'm sure you would agree that gathering up research and data in this space and having that inform this perspective on the health impacts of structural racism is also a key undertaking. What significance would it have to establish a national center for anti-racism to serve as a resource hub to share information at the federal, state, and local levels, in your view?
I think that the benefit is that we could make sure that there is some data standardization, but also expertise that often is not accessible in state agencies. So having a national center can lend technical support, can lend some data standardization, but also can support facilitation and collaboration with academic partners and state and local data. And I think having those resources come together in a national center can be very beneficial, and can't necessarily be done 50 times over in other areas. So I think that the National Center, we've worked with them in the past, and I think it can be a great resource.
Thank you. Ms. Blauer, at Johns Hopkins, and let me just say how proud I am, being from Baltimore, about the great work that Johns Hopkins has done, particularly gathering critical data during the pandemic. And the university's Coronavirus Resource Center, as we all know, was a trusted source of information for so many people over the past year. Could you expand on the role data played in responding to the pandemic and what additional data and resources might have been helpful, particularly to respond better to the challenges faced by communities of color during the pandemic?
Yes, thank you, Congressman. I can say that it wasn't until several months into pandemic response in our work that states even started to release COVID data, demographic data that was rich enough for us to even validate the kind of frontline anecdotal information we were getting about the disproportionality that the virus was having on residents. And it's taken us a long time to even get any kind of guidance around demographic sharing of data. We're still only at the CDC reporting around 60% of demographic data for the cases and the deaths of people that have been impacted disproportionately by the virus. We are still operating certainly in an environment of confusion when it comes to the disproportionality and the effects. And so having some guidance and some standardization around demographic data is so vital as we continue this last mile of work around COVID, but certainly as we think about how we look at the social determinants of health and the role that data plays in deepening disparities and exacerbating bad outcomes for people. Thank you.
Thank you. I yield back.
Gentleman's time has expired. The gentleman from Georgia, Mr. Carter, you're recognized for your 5 minutes of questions.
Thank you very much, Madam Chair, and thank the witnesses.
Are you in the car? Where are you?
No, I'm in the hearing room.
Oh, good. Okay, glad you got out of your car.
I am too. Thank you, Madam Chair, and thank the witnesses for being here. Very important subject matter. Dr. Batra, I apologize, Barter, and Dr. Syed, Medicare Advantage plans have more than doubled enrollment over the past decade. And these plans clearly offer beneficiaries greater benefits and care versus traditional fee-for-service plans. And this is good. This is a good product that obviously is being utilized, and I'm glad to hear that. My question, Dr. Batra, is this: how would beneficiaries benefit by Medicare Advantage plans offering new and existing breakthrough technologies and devices that are FDA approved, but do not fit into an existing benefit category for certain targeted populations like those with chronic conditions?
Yeah, I think what we have done consistently is look at, as these new things become available, what has shown proven evidence, what has shown to prove help with the needs of the membership that we serve. Wherever we have, guidance from Medicare, either through their NCDs or LCDs, we follow those guidances. Where we don't have guidance available right away, we look at other data sources, other peer-reviewed studies, other evidence-based sources, and see if we can fit the need of the population and go from there on. The other thing that we have done and encouraged in our members is, as things become available, some of them are in the experimental trial phases, which is available to them.
I don't mean to interrupt
Medicare
you, but I indicated if they were FDA approved.
Oh, if they're FDA approved, then we do have the flexibility in evaluating what's available in terms of evidence, and then considering them for the right populations.
Okay, and you have a review process for that, whereas you review it among yourself to decide whether it's going to be covered or not?
Yes, we do have a medical policy departments that work together alongside our provider partners, working very closely with our provider partners alongside experts. Some of them are academic experts, to review them on a case-by-case basis, to look at the needs in a population, to look at what else is available, to look at their comparative effectiveness. So multiple factors play a role in that.
Okay. Dr. Saya, what about you? What about your company?
We understand that more than 70% of modifiable health outcomes are actually based on preventive lifestyle interventions. So when you have a system that's focused on prevention, and the doctors are allowed to focus on prevention, then the patients are more safe at home rather than going to the hospitals. It eliminates all the medical costs actually before they even occur. We focus on improving health and reducing suffering through preventive and early interventive measures. If there's an FDA-approved treatment or a product that can help benefit the patients, then as long as it's FDA approved, then we would evaluate that on a case-by-case basis.
Do the individual patients have some type of appeal process, some kind of prior approval process or anything through your company?
I am not, usually in the full risk model, I'm not aware of having to go through that type of process.
Okay. All right, let me move on. Dr. Batra, again, I serve a very rural community, and many of my constituents have trouble getting to physicians for care. Even during the past 6 months, many of these same constituents could not access vaccines for extended periods of time. It appears that SCAN health plans have been recognized as a leader in getting COVID vaccines to homebound and rural patients. Can you share with us what y'all are doing that maybe other plans could duplicate to improve access to care for beneficiaries in rural communities?
Absolutely. We absolutely follow the principle of leave no older adult behind. So right from the very beginning, as the vaccine was being developed, we put all hands on deck in figuring out how do we get the right people to right places. Those who could drive, how do we get them there, give them information? And those who could not get there, how do we get them rights to get there? But we also serve a large swath of people who are homebound members who have caregivers taking care of them. So we worked very closely with an organization that then deploys paramedics in people's homes that could carry the vaccine in a safe way, had an oversight provided by nurses and physicians. We were able to schedule those visits for them, and within the comfort of their own home, under a watch of a paramedic as well as the oversight of a nurse, we were able to deliver those vaccines in people's arms. To date, we have done several hundred of those, and we will continue doing that with the goal of leaving no older adult behind.
Well, I just want to compliment you and thank you for your service to the rural communities in particular. It's extremely important. So thank you, and I'll yield back.
The gentleman yields back. And now another one of the doctors on our subcommittee, Dr. Ruiz from California. You're recognized for your 5 minutes of questions.
Thank you, Chair. This is so important. Finally, it is a pre-med dream come true. You see, back in the 90s when I was pre-med and in medical school, those of us who understood social determinants of health would shout it out in lectures, would talk about it in the halls of the different academic hospitals, and everybody was so singularly focused on the specifics of medicine that they didn't really understand. And now we're actually having a hearing on how to improve data collection for social determinants of health in our public health system. This is groundbreaking. This is incredible. This is the spear of much more to come, the tip of an iceberg. And I am so proud of Congressional Hispanic Caucus member Nanette Barragan and all the other members of our committee who have pushed forward great legislation to finally get our social determinants of health in the limelight so that we can really take a comprehensive look at health. It's not just the absence of disease. It is the ability to enjoy one's life and have wellness and fulfill our human potential in our communities. And from breathing in the toxic air around the Salton Sea in my district to working in the fields, the grape fields, the bell pepper fields under the blazing sun, to food insecurity, I have seen firsthand in my district how social determinants negatively affect my constituents and my patients. I'm an emergency physician, by the way, my patients' health. So many of my constituents do not have access to healthy foods, whether that is because they live in a food desert or because healthy food is more expensive. Ironically, the same farm workers who pick the healthy foods can't afford those healthy foods at this in sometimes, or they do not have adequate health insurance. So no matter what the reason is, all these factors contribute to higher rates of underlying chronic diseases like obesity. In fact, nearly half of Black and Hispanic Americans are living with obesity, and this puts them at greater risk of 200 serious diseases, including serious conditions like diabetes and heart disease and serious complications of COVID-19. This is why I joined several of my colleagues in introducing H.R. 1577, the Treat and Reduce Obesity Act, which would increase access to effective treatments for obesity. Bills like the Treat and Reduce Obesity Act, as well as several that are under considerations today, will help us address some of these social determinants of health straight on. And while it is critical to address the social determinants of health in order to improve the health of all Americans, we cannot do that without really understanding the problem. And to really understand the problem, we need adequate, accurate, and timely data that describes the social factors that impact health outcomes, like economic status, access to transportation, access to healthy foods, educational attainment, housing, and environmental influences on health. This data has been challenging to procure in public health, in part due to a number of barriers that range from inadequate design of systems like electronic health records to the use of phone survey systems and a lack of trust for those being asked about their social risk factors. Dr. Desalvo, can you speak more on the importance of collecting health quality data on the social determinants of health, and then how to translate that into actual policy and public health programs?
Congressman, let me just first say I woke up with that same enthusiastic pep in my step today. This is like 20 or 30 years of work and all the data, equity, and public health together. And the social determinants are just the things that I care so passionately about. So appreciate your enthusiasm. Really look forward to working with you and others as we bring this to fruition. Maybe I'll just harken back to my experiences in New Orleans, since you mentioned obesity, and say that when I was health commissioner, that one of the first, when I went 2 blocks down the street from my medical school, where I was faculty and took the helm of the health department, I had in my head all the information from the quantitative survey data I'd seen saying that cardiovascular disease and cancer were killing people in my community, and I needed to focus on that. Within the first 5 minutes of the first coffee I had in a church hall, they said, our priorities are violence, mental health, and economic opportunity. And it was a real mind shift for me of really respecting and appreciating that the data I might see that's quantitative and collected in some ways doesn't always reflect the now and not what's on the mind of my community. And so mixing qualitative and quantitative is important. We can scale that by leveraging novel data sources. I mentioned earlier search symptoms trends that public health could use. It's anonymous and can give them a snapshot of their community. But I took those lessons from them and I looked at a through line and realized that fitness, obesity, lack of nutritional fitness were contributing to cancer and cardiovascular disease. And as I talked to them more, I realized they needed sidewalks, playgrounds, access to healthy foods. We had to work with our economic department to get grocery stores to go in communities. We had to work on school lunches. Kids designed it, told us they wanted, how they wanted the salad, what would drive them to go away from French fries and pizza and have some other healthy food. We did it with kids, not for them. So I think what once you have the data in front of you, quantitative and qualitative, local leaders can bring people together and that community can make decisions about how to make interventions and measure success so we can know what works and continue on that generational trajectory of improving health.
Wonderful. I love it. Thank you all for the work you do.
Gentleman's time has expired. The gentleman from Florida, Mr. Bilirakis.
Thank you, Madam Chair.
You have 5 minutes for your questions.
I appreciate it. Thank you. Thanks for holding this very important hearing. Madam Chair, data drives decision-making, as you know, and the integrity of these decisions lies in the integrity of the data. As you know, I'm from the great state of Florida, and Florida's COVID-19 story is one of success driven by reliable data and following the science. I've included a press release exposing myth versus fact regarding Florida's COVID-19 data, and I ask unanimous consent that this be entered into the record, Madam Chair. Madam Chair.
Did you hear it? So ordered.
Yeah, okay, thank you. Yeah, I didn't hear that. Thank you. Dr. Walker, Representative Blunt Rochester and I introduced the bipartisan collecting and analyzing resources integral necessary for guidance for Social Determinants Act, and it's HR 3894. And what it does is it provides regularly updated guidance to states to address social determinants of health under Medicaid and CHIP, building upon the success that some state Medicaid programs have already had since testing innovative delivery and payment models. Additionally, several members of this committee are championing the Social Determinants Accelerator Act, which is HR 2503, which would help states and communities devise strategy to better leverage existing programs and authorities to improve the health and well-being of those participating in Medicaid. So my question is, a couple questions. How might HHS do more to coordinate social determinant efforts, even without additional congressional authority? And then also, could you explain how HHS could use its leadership in Medicaid to more broadly catalyze efforts to better coordinate and measure the impact of resources and initiatives that address social determinants of health? And this is for Dr. Walker.
Thank you, Congressman, for the opportunity to address this question. It is absolutely critical to think about how to refine ongoing guidance to states around how to address social determinants of health. We know these impacts continue to evolve, and so even when I was State Secretary of Health and Social Services, it was extremely helpful to have this updated guidance provided. It informs waivers, it informs how you can think about state plan amendments, and as you mentioned, doesn't require necessarily additional authority, but gives clarity around where existing resources can be deployed and used most efficiently. And there are several models out there. So another strategy could be that models like that at the state level are incentivized through the MMI or other waiver authorities like North Carolina's. I expect we'll continue to learn from these models. So having evaluations and the data available can be incredibly useful, but also providing resources for technical assistance, updated guidance, and examples are tremendously beneficial. Thank you.
Thank you. And the next question is for Dr. Batra. Recently, I introduced HR 4074, the Addressing Social Determinants in Medicare Advantage Act, which increases flexibility for Medicare Advantage to offer supplemental benefits that would help address social determinants of health. Can you discuss how supplemental benefits have improved the lives of your members and how adding benefits that address social determinants of health in Medicare Advantage and broadening beyond just those with specific chronic conditions would mitigate social inequities and allow plans to assist even more members in need?
Absolutely. I had shared with the committee before, we really appreciated getting that flexibility. Post that flexibility, we have designed multiple newer benefits. I mentioned our benefit called Return to Home around medications, care coordination, and in-home caregiving. We also introduced benefits like respite care for our populations who have caregivers who could use that kind of a help. So we've used benefits for that. Beyond that, we extended our meal benefits to provide meals for our folks suffering from chronic conditions who perhaps need that a meal for their diabetes or need that meal for their end-stage renal disease that is appropriate for their condition, so they can have a better food lifestyle in order to improve on their chronic conditions. So those were a few high-level benefits that we introduced. We have seen, based on our either both the utilization adoption data as well as our outcomes data, when we look at our utilization from ER visits or admissions or improvement in diabetes control and improvement because of those kind of benefits. We continue looking at more benefits, and as I had shared with the committee, would love to have benefits based on your social needs versus just based on your medical conditions. Right now, we do have the flexibility, but they're still tied to chronic conditions like diabetes or heart disease or cardiovascular disease or chronic kidney disease. But we know, as I shared, we have about 20% of our membership that has at one time or the other shared with us they have food insecurity. We would be able to do more if we were able to address needs of larger population, not limiting ourselves just to chronic conditions.
Thank you. And I just want, Madam Chair, this particular bill, H.R. 4074, I filed it due to timing alone, but I welcome bipartisan support, both in this committee, Ways and Means, and any members that want to. I think this is a very important issue for the constituents. Thank you, and I yield back. Thank you for the extra time, Madam Chair.
Yeah, the gentleman yields back. Pleasure to recognize the gentlewoman from Michigan, Ms. Dingle, for 5 minutes of questions. Right there from the very beginning and taking everything in. And I think we hear more bounce in your voice, so you're feeling better.
We're getting there, slow but sure. Thank
Good.
you, Madam
Good,
Chair. Good. Wonderful. And Ranking Member Guthrie for convening this hearing to discuss legislation to address deficiencies in public health data and technologies, which I really care about. As our witnesses have mentioned, the HITECH Act and funding have led to improvement in data collection that have helped drive better outcomes for patients in the clinical settings. However, while we've seen additional resources directed at gathering and disseminating actionable public health data during the COVID-19 pandemic, longer-term reforms are needed to address these gaps in our public health data infrastructure. Additionally, doing so will allow us to better direct healthcare resources towards areas of greatest need to better address deep-seated inequities in disadvantaged communities or populations. And I love seeing Dr. Wes excited. So I want to get him the data he needs to be able to do that. But my questions are for you, Dr. Batra, because it was good to see you highlight the Independence at Home program in your testimony. IAH ensures Medicare patients can maintain their independence while meeting their unique medical needs and lowering costs. And I was glad to partner with my colleagues on this committee as part of a bipartisan effort to successfully reauthorize and expand the IAH program at the end of last year. Dr. Batra, you also mentioned that voluntary health risk assessments used to identify members' health needs have a 35% response rate, not very good, with a completion rate of 80% for special need plan members. What barriers do you see in raising response rates for these assessments?
Absolutely. Right now, the way we do these assessments are either over the phone or through mailing, but you're absolutely correct, we could do more. We have a significant membership that is aging in and joining MA plans, including ours. For them, we have to be ready to provide online assessment if that's the way they want to engage with care. So that's one area that we are exploring. The other area that we are also exploring is for folks who perhaps are homebound, have caregivers who are really busy doing other things and not have the time to fill out the assessments, or they're not available themselves to fill out the assessments. So could we go into their homes and help do those kind of assessments to get a better idea on them? That's the second way of doing it. The other things that we are also exploring is filling out these assessments in different languages. We are based out of California. We serve a diverse population that speaks many different languages. We right now have assessments that are available in 3 to 4 languages. We need to address the needs of our population. We really have to expand those languages as well, so we can really get feedback from all of our members, not just some small swap of our members. So those are a few areas that we are thinking about. And then finally, our providers also do a lot of assessments, and we are looking at interoperability to say, hey, where we do not have those assessments, perhaps our providers have it. How do we get that data and build it in our system so that we have a more holistic understanding of our population?
So let me follow up on that, and I'm going to run out of time, so I'm not going to be able to ask all my questions. But how do non-responses and other gaps in data affect your organization's ability to provide targeted intervention to seniors based on social determinants of health?
It does make a big difference because we generally, when we get this data, that's where we act on. We have an algorithm to say who's going to reach out, who should be offered certain programs, who should be enrolled in certain services. So we are always looking, how can we make our data more comprehensive and robust? And our approach has been to work with our providers to see how we can further make the data more comprehensive. Our approach also has been, how do we engage with caregivers? Perhaps they are also the people who can help us in getting those assessments completed. How do you work with community-based organizations, folks like Meals on Wheels that perhaps are going in people's homes, and get data from that perspective? So we are trying to look from everybody who's available at the community level, at the individual level, at the provider level, at the delivery system level to make the data complete.
Okay, so I'm going to rush a question. So missing, incomplete, or non-standardized public health data is more common than anybody would like, particularly when it comes to long-term services and supports, as well as other services utilized by our nation's seniors, which I care deeply about. And I was a caregiver. Yes, I could have filled it out better than anybody. But how would uniform public health standards, like those in the Health Statistics Act before us today, as well as improved quality measures for LTSS, improve your organization's ability to meet the need of older adults your organization serves? And you have 1 second.
Absolutely. We do have a fully integrated dual eligible special needs plan. So we do offer those long-term services and support. So we absolutely believe in the importance of it. And so we're working with in-home community partners, caregivers, formal and informal, in completing the data.
Okay, thank you. I yield back, Madam Chair.
The gentlewoman yields back. Pleasure to recognize the gentleman from Utah, Mr. Curtis, for your 5 minutes of questions.
Thank you, Madam Chair. I'm pleased to be here today. Dr. Batra, my bipartisan legislation, co-led by my friend Mr. Cardenas, that we're discussing today, aims to give private individual market health insurance plans more flexibility, an incentive to spend money focused on improving patient outcomes. It does this specifically allowing plans to count social determinants of health expenditures toward the Affordable Care Act's medical loss ratio requirement. Services could include partnering with ride-sharing companies to help beneficiaries to get to and from appointments, or even paying for groceries. While SCAN is a Medicare Advantage plan not in the individual market, could you explain how insurance plans are engaged in providing social determinants of health services to beneficiaries?
For us as a MA plan, we design our benefits based on the supplemental benefits that are made available. One more time, they are made available based on the chronic conditions that they have. We look at our ongoing data and look at opportunities to close gaps in care, whether they be social gaps in care, or in some contexts, it may be even medical gaps in care, like affordable medications or access to telehealth vendors. So our approach of planning and designing benefits is based on that approach, and also offered through the Congress, giving us the flexibility to design these kind of benefits with social needs as one of the drivers.
So that plays right into my next question, which is what can Congress be doing to help offer incentives to help you do your job better?
In my mind, offering these benefits in a more holistic manner would really help us a lot. So right now, the benefit, one more time, are based on your medical condition, which we know is the driver for 10 or 15% of your overall outcome. If we were able to design those benefits based on your social conditions, perhaps you are housing insecure and do not have other chronic conditions that may have qualified you for a benefit, that would be one idea for us to do it. And also thinking of populations that perhaps are not completely fitting into the MA mold, so people experiencing homelessness, could we offer them some differentiated benefits based on their social needs versus just their medical needs? Another one that comes to my mind.
That's good, thank you. Could you comment on this along those same lines? Would it be helpful to remove some of the barriers, such as reforming Stark Law, and could that enhance care coordination between providers, increasing savings for the patients?
It's always great being a primary care physician. The more we can collaborate and coordinate with a primary care physician, not only just the primary care physician, but their teams and their extensions of their teams, whether it be in the hospital setting or be it in the ER setting. We're always looking at opportunities to do more of it, whether it be through the data exchange, or it be through our teams or working closely together.
Thank you. Dr. Desalvo, could you talk for a minute about how Google's partnering with healthcare systems or insurance plans to gain a stronger understanding for healthcare trends in certain communities or within patient populations?
Thank you for the question, Congressman. I think one of the opportunities that we all have has come up in the hearing, and that is how can the data that's already available be more intuitive, more accessible, easier for the doc or nurse to find right at the bedside or in the clinic? Also for the patient, how do we minimize or reduce the need for them to repeat over and over again what their medical conditions are, or in the case of social determinants, to have to prove they're hungry or unhoused over and over again? What are the ways that we can be more efficient and effective with the data that we're already collecting? And so in that context, Ascension Health System asked if Google could be helpful to apply that notion of making the electronic health record data easier to find, and make it more intuitive for doctors when we're trying to make sure we can not only get through the day with our patients, but be able to spend time looking them in the eye and not looking at the computer. So that's an example of how we're working on data.
I'm going to jump in on you simply because we're so short on time. Okay. Talk to me for just a little bit about privacy of this data, and how do we put patients totally in charge of their own data and still reach our interoperability goals? Is blockchain technology, what technology is out there that we can be thinking about to give patients total control over their data?
Oh, thank you. Thank you for raising that, because first and foremost, people do need to understand how their data is being used. That's the transparency piece. They need to have choice about who's going to get it, and then control across the journey. Something that I spent a lot of my career working on. And in fact, as we talked about earlier today, 21st Century Cures pushed this idea of APIs, doorways to the data that consumers control. So it's a great example of how consumers have the control of saying, I want this data and I want to share it in with these trusted healthcare partners, for example. All of that would fall under and with consent. So the notions are already there and the systems are building them. The last administration in the interoperability rule further pushed this idea technologically. But you're raising an important additional concept, which is, are there ways that data isn't all stored in one place and that it can be visited or borrowed in the moment when the person's either critically ill, having a heart attack, or when you need to use it for more long-term diabetes care? We're pretty early in the journey of knowing how tools like blockchain will work, though there are many in the healthcare environment, in the technology environment, trying to understand it. But I just want to emphasize the point again that consumers do.
Gentlemen's time is.
Yes, I'm so sorry.
Expired. I'm sorry.
Yeah, Madam Chair, I yield my time. Thank you, and hope we can explore that in more detail later.
Delighted to.
Good. Pleasure to recognize the gentlewoman from New Hampshire, Ms. Custer.
Thank you very much, Madam Chair, and thank you for bringing us together today to discuss the opportunities in legislation to bolster equity within public health. Today's hearing is timely as we continue to safely reopen our economy from the grips of the COVID-19 pandemic and examine many of the underlying health inequities that existed before COVID. I've often said that this pandemic pulled back the curtain on so many health inequities and injustices, and it's critical for this committee to identify and advance legislation that will support the healthcare delivery and public health approaches for these impacted communities. One of my main focuses in Congress has been addressing health access issues in rural communities, which are oftentimes underserved and under-resourced to address their unique health challenges. We need to take a comprehensive approach to tackling this problem, which includes everything from expanding primary care options to increasing access to fresh foods and produce. The existence of food deserts represents a real challenge for our rural communities and is directly linked to worse health outcomes for rural Americans. Without access to fresh food, Granite Staters live in food deserts may be at higher risk of diet-related health conditions such as diabetes, cardiovascular disease, and obesity. So that's why I'm so pleased that today's hearing includes legislation sponsored by my colleague and good friend, Congresswoman Cheri Bustos, the Social Determinants Accelerator Act, which I am also proud to support. Economic and social conditions such as stable housing, access to transportation, and healthy food have a significant impact on public health and wellness. And this legislation will help states and localities devise strategies to leverage existing programs and boost health outcomes. So my question is for Ms. Odom Walker. Ms. Walker, your testimony touches on this bipartisan legislation and the positive impact it will have on health infrastructure investments. Can you expand on this and discuss how this legislation will help rural communities address health disparities and negative social determinants of health?
Thank you, Congresswoman, for the commitment and need to elevate issues around inequities. And there is an interconnection between how we look at health and all of the social factors that influence our health outcomes. Being able to accelerate what works and do more of it along the lines of creating partnerships between federal, state, and local agencies is important. And we know that in the light of the pandemic, that those interconnections were even more important, that inequities were highlighted. And so having the ability to provide technical assistance and resources to make sure that we are doing more of what works and focusing on the communities of greatest need is critically important. And we know that those technical resources aren't always available, and having the data, having the know-how to really move beyond what's currently being done would promote health more broadly.
Great. Well, thank you. Now, your expertise is children's health, and I appreciated you highlighting the intersectionality of children and maternal health. Can you discuss some of the specific challenges that parenting women face in rural communities, and how can this committee advance meaningful legislation to tackle the underlying negative social determinants for new mothers and their children?
Absolutely. I think, again, it shows in the midst of the lifelong journey of health that health often starts preconception. It starts during a healthy pregnancy, and the health of mothers is linked to the health of their children. And rural communities often don't have those same wraparound services, but could be supplemented by home visiting programs and other factors, other supports. We know that factors like trauma and stress of the mother, even before conception, can impact the life course of the child well into adulthood. We need to make sure that there are resources for addressing maternal depression, and some of that could be supported through telehealth supports, even if local resources are not available. But I think some of these other factors around nutrition and how we really think about creating that support impact both cognitive well-being and others. So trying to figure out how to deploy some of it through telehealth resources as well as local community resources can be a benefit, particularly in rural communities.
Well, and thank you for your reference to telehealth, because often transportation is a real barrier to access to healthcare. And with that, on the stroke of zero, I will yield back to the chair. Thank you so much.
Excellent. Thank you. Pleasure to recognize the gentleman from Texas, Mr. Crenshaw, for your 5 minute questions.
Thank you, Chairwoman. Thank you for holding this hearing today. It's an important one, and I want to talk about the variable that we're trying to understand, the social determinants of health that goes and going all the way upstream to understand what might be impeding access to care or what is preventing people from living a healthy lifestyle. So I'm glad to hear that our private plans are working on this already, and as I know, many of them are solving problems of nutrition, which is a really critical piece of preventing health issues through food. And one example is through food subscriptions like HelloFresh. Many offer rides through Uber or Lyft so they can get access to their doctor. So first, I think we have to make sure that the government isn't putting barriers in place that would impede private plans from addressing social determinants. And I'm glad that my colleagues, Mr. Curtis and Mr. Cardenas, have a bill to do just that. Second, as we think through how to properly integrate these social determinants into our public health plans, I want to make sure we're thinking through social determinants as a piece of the puzzle and not the sole solution to healthcare problems. Finally, it's important to acknowledge that as we use social determinants to improve health outcomes, some of our most fundamental healthcare programs are still in desperate need of real programmatic updates. And simply integrating social determinants won't get at some of the most critical issues with Medicaid and Medicare, which is the fee-for-service system. So even the most straightforward solutions are really complicated by rules regarding payments and what regulations on what services to cover. Dr. Batra, my first question is for you. What lessons can the federal government take from the private plans on how to properly balance social determinants as they're integrated into our more complicated public healthcare system?
I think the few things to learn from MA plans, I can speak for my plan, is having a very person-centered view and starting from what matters to the patient. And what matters to the member or a patient or a beneficiary is access, affordability, experience, and living the life to the fullest. So you have to balance all of them out. Medications is a big deal for them. So having affordable medications available to them. Access is huge, and access getting to the doctor. So that's where social benefits become important to it. But also when you cannot get to the doctor, how do you get to access, whether it be through telehealth or it be in-home health if required, is another piece of the
Can we get to that point without actually innovating the process of what we choose to cover? I mean, without reforming the fee-for-service system? Will traditional Medicare have to create and approve new benefit categories for, those Ubers or that nutritional support? Is that really the most effective way?
That is true. You will have to overhaul it. Like hearing aids, for example, is not a Medicare covered benefit. For being a primary care physician, dental is so integral to your medical health as well as your overall health is now currently covered by Medicare. There are other areas like vision is not currently covered by Medicare. So there have to be certain areas of priority, and given today where we are, technology can play a lot of role in some of these areas. As we think about rural area, for example, telehealth access could be one of them.
Right.
Similarly, addressing social needs could be another one of them. And yes, we can deliver food much better now, perhaps, than we could have done it a few years back. So those all become core to it. And you're right, there has to be a balance between social and medical on both sides. I would say not only social and medical, but functional and behavioral as well.
Thank you. My next question for Dr. Syed, based on your primary care experience, the practice you represent is dedicated to improving primary care for seniors. And I'd like to know, would integrating a program modeled on direct primary care, which currently does not exist within our federal payers like Medicare and Medicaid, but would allow for beneficiaries a personal primary care coordinator, would you find that beneficial to improving health outcomes?
I find full risk, full capitated doctors and direct primary care doctors having much in common. I oftentimes compare our both styles of practicing medicine. We're both two arrows that have been shot out of the same fee-for-service bow. Definitely, there's a population of patients that would benefit from direct primary care. I believe now there are over 20,000 direct primary care doctors out of 200,000 primary care doctors in the country. So for a set population, I see there being benefit there. But in the world where I live in, my patients are struggling with the basics. We have centers, for example, in St. Louis, where more than 90% of the patients rely on us to provide them transportation services.
Mm-hmm. In my remaining time, could you also comment on the question I asked about moving, from a fee-for-service to a value-based system, and how that is necessary to really innovate and to be able to cover these social determinants?
Absolutely. I would like for you all to think about value-based care, or especially the fully capitated value-based care model, as full responsibility, where the doctors, the primary care doctors, and the primary care delivery team assume all the responsibility. If the quality of the care is expensive, it's on the doctor.
Yeah, the gentleman's time is expired. I'm sorry to interrupt.
Sure.
Okay.
I yield back.
Thank you.
My negative time.
Thank you.
Thank you, Chairman.
I now would like to recognize the gentlewoman from Illinois, Ms. Kelly, and for those that are with us today as witnesses, she really is the mother of the issue of maternal health on our subcommittee. So, Congresswoman Kelly, take it away. Are you there?
Seems like she's having technical.
She may be having technical difficulties. Let's give her a few minutes to straighten. Are you there, Robin? Pardon? No, I think there's something wrong. There's something wrong with your audio. Maybe they can get it straightened out and we'll come back to you. I will recognize the gentlewoman from California, Ms. Barragan, for 5 minutes of questions.
Thank you, Chair Eshoo, for holding this important hearing on advancing equity in public health and for including my bill, the Improving Social Determinants of Health, as part of the conversation. I also want to thank my committee colleagues who have co-sponsored.
Can you hear me? Can you hear me?
Maybe we can ask her to mute.
If Robin is on and I don't see you, please mute, and we're going to circle back with you. But there is some background noise, so make sure you're muted, and we'll be back to you in a few minutes for your 5 minutes of questions. You can proceed.
Thank you, Chair Eshoo. I also want to thank my committee colleagues, representatives.
I know, Anita. I don't know what.
I want to thank my committee colleagues, representatives Butterfield, Cardenas, Clark.
I'm not recognizing you now because we had some audio problems, but so please mute so that we don't have your background noise. Congresswoman Barragan has her 5 minutes now, and we'll circle back to you. Okay.
I will text
Representative
Kelly, and if committee staff can text her and her staff as well, I think.
Well, my staffer is contacting her staffer. It's like, my office calls yours, but it's not, so far it's not working. So I'm trying to intervene by saying so. Okay, Ms. Barragan, you can proceed. Can we give Representative Barragan a full 5 minutes due to those? I'm not taking time out of her time for the interruption. You can proceed.
Okay, thank you, Chair Eshoo. I also want to take a moment to thank committee colleagues, Representatives Butterfield, Cardenas, Clark, Blount, Rochester, Rush, Kelly, Welch, and Castor for co-sponsoring this critical legislation. The COVID-19 pandemic has had a devastating impact on communities of color. My district is nearly 90% African-American and Latino. And I have seen what the crisis has done to low-income and underserved communities that don't have access to the services they need. Lack of access to transportation, unsafe or unstable housing, and food insecurity put individuals at a higher risk for worse health outcomes. Addressing these social determinants of health is crucial to reducing health disparities, not only during the current crisis, but as we work to strengthen our public health infrastructure into the future. That's why I introduced the Improving Social Determinants of Health Act, which would provide funds to the CDC to establish a program focused specifically on social determinants. It would also establish a grant program for local public health departments to tackle these underlying issues that contribute to inequity. Dr. Walker, how have social determinants of health contributed to minority health disparities, including worsening health outcomes for those in underserved communities, and why have these factors made it harder to care for communities of color during the recent pandemic?
I think one of the first things that I recognized when the pandemic arrived in Delaware was that the communities of color would be most dramatically impacted because they were unable to follow my basic advice of stay home and stay safe. They had to go to work, they had to put food on the table, and they were worried about their livelihood and staying housed. And I think those are the challenges that we're trying to navigate as you think about social factors. How do we bring them together when issues around poverty and food insecurity all coalesce? So having resources, technical assistance, data to inform better and more efficient program delivery or community health worker support or linkages would be a tremendous asset, not only to emerge from the COVID pandemic, but also to promote better health at local communities to really address the inequities that we've long known existed, that we could start to think about structural racism and the multi-level interventions that need to be developed and addressed And we'll have to do it collaboratively with community voices, with stakeholders engaged from the start. Thank you for that question.
Thank you. Ms. Blower, data from the CDC found that African Americans and Latinos were nearly 3 times more likely than white Americans to be hospitalized with COVID-19 and twice as likely to die from the virus. Factors such as a lack of insurance, limited access to healthcare services, working in occupations in which telework is not an option, and being more likely to face eviction and homelessness in times of economic instability are only some of the reasons these disparities exist. Unfortunately, there's a lack of complete, accurate, and standardized race and ethnicity data to help paint the full picture. The question is, what existing state and federal data infrastructure should be used to ensure clinicians and health systems and health plans that are implementing programs to address social determinants of health have accurate and comprehensive data on patient populations who would most benefit from these programs, and where does the federal government need to make additional investments?
Thank you, Congresswoman. It's a very good question, and it's one that I've been thinking a lot about over the course of the last 17 months. We still are completely in the dark in really understanding fundamentally where populations had major obstructions to even accessing the very basic tools that they needed to navigate this pandemic, like testing and vaccine access. And that's because of the limitations on demographic data that has been paired with the release of COVID-19 information. So first and foremost, there must be standardization and requirements on how data is collected and how data is shared from local authorities, health departments, state health departments to the federal government. And there needs to be an optimization of not only how that data is collected, but how that data is broadly shared so that local policymaking can align to where those needs are, so we can deploy the resources so that people that are living in communities, particularly those that are disproportionately affected by health disparities, have equal access to the very tools that they're going to need to navigate not only this pandemic, but the very real health challenges that are associated with navigating all the social determinants of health that you've remarked on in your comments today. So thank you for the question.
Thank you so much. And thank you, Madam Chairwoman, for your patience given the interruption. With that, I yield back.
You're most welcome. Now let's see if our friend, Ms. Kelly is, I see her room on the screen, but I don't see her.
Madam Chairwoman, Ms. Kelly is in a dual committee,
Okay.
and so asked if
All right,
I would go ahead.
then the chair will go to recognizing the gentlewoman from Delaware, Ms. Blunt Rochester, for your 5 minutes of questions.
Thank you so much, Madam Chairwoman, for the recognition. And thank you to all the witnesses for being here today to discuss the important slate of bills at the intersection of data, health equity, public health infrastructure, and healthy outcomes. I also want to give a special thank you and recognition to Dr. Kara Odom Walker from Delaware. Phenomenal job, and thank you for being here today. I'm also pleased to see 2 bills from the Black Maternal Health Momnibus Act being discussed today, and I look forward to having my colleagues support our bill, my bill. It's a bipartisan bill, the Moms Matter Act, HR 909, which is part of the Momnibus. The Moms Matter Act would make community investments to support moms struggling with maternal mental health and substance use conditions, and also grow the healthcare workforce in those sectors. We know that maternal mental health is deeply tied to and predicted by the social determinants of health. Given that next month is Black Maternal Mental Health Awareness Month, I hope that the committee will consider this bill and the entire Momnibus. And Dr. Walker, could you share how would improving maternal mental health and the health of mothers impact the lifelong health trajectory of their children?
Thank you for your leadership to our great state. I have to say that investing in maternal health, particularly around mental health, does have long-term impacts. We know that they are linked. We know that factors that happen early in preconception around trauma and stress during pregnancy and early postnatal care risk their own lives, but also that of their child. And it is a huge factor in how children develop. So maternal depression is linked to so many other outcomes for children, their economic success long-term, their ability to succeed in school, the likelihood that they'll access childcare and early education. And I think what we know is that even things around preconception diet all have long-lasting impacts. So if we can really think about the cognitive and behavioral development and the support of moms, making sure that we're looking at maternal depression, can ultimately impact a generation, ultimately impact the well-being of the child. And I think what we've seen in COVID is that this issue is more important now, more than ever.
Yes, well, shifting gears, Americans with lower incomes are frequent targets of tobacco industry marketing and often face financial and other stressors that can lead to continued tobacco use. As we know, tobacco use is a key driver of poor health outcomes and a major health equity concern. Medicaid enrollees use tobacco at more than twice the rate of those with private health insurance, yet Medicaid tobacco cessation treatment is often less comprehensive than what private health insurance plans are required to provide. In addition, there are barriers such as co-pays and sometimes prior authorization or step therapy that can also impact the insurance types. Tobacco use also negatively impacts our nation's children. More than half of all children with asthma get their coverage through Medicaid and CHIP, and exposure to secondhand smoke can cause asthma attacks. That's why I was proud to introduce the Quit Because of COVID-19 Act, HR 2125, which would expand comprehensive tobacco cessation coverage to all Medicaid and CHIP enrollees. Fundamentally, this bill is really about equity, giving Medicaid enrollees equal access to effective tobacco cessation treatment so that they can live healthy lives. And as we talk about recognizing and addressing social needs and improving health data systems, I can't help but think of Delaware's leadership as the first state to launch a statewide health information exchange back in 2007, the Delaware Health Information Network, otherwise known as the DIN. And so, Dr. Kara Odom Walker, if you could just speak a little bit about the opportunities to leverage clinical health information networks like the DIN to strengthen our public health data and public health response to both pandemics and the social determinants of health.
Thank you, Congresswoman. But we know that health information exchanges make it easier to exchange clinical information for treatment, care coordination. All of the witnesses have talked about that interconnection. And we are very fortunate to have a statewide health information exchange. This would allow us to really think about an opportunity to expand HIE's ability and strength to not just look at clinical data, but also how we leverage social determinants of health data, because they are interconnected and they are causal, and they really do indicate the need. We really do need, as physicians, to think about the wraparound indicators around health, not just what's happening in that one-on-one patient encounter, but what happens when they're home, when they're at church, when they're in their communities. And I must say the pandemic has shown us that even more data integration across state lines is challenging. And so having the ability to share information in that way could be incredibly helpful. For COVID, we needed that. We needed to create a response across state lines.
Thank you, Dr. Walker. Thank you, Dr. Walker. And I yield back, Madam Chairwoman.
Okay. Let's see. We need a band to welcome her back. Are you there, Robin? There you are.
I am here. Can you hear me?
Wonderful. All right.
Okay.
I'm thrilled to recognize you for your 5 minutes of questions.
Thank you.
Thank
Thank you, Chairman Eshu and Ranking Member Guthrie for holding this hearing to discuss how we can improve our public health data infrastructure to advance equity and address social determinants of health. The COVID-19 pandemic has highlighted the gaps in our public health data infrastructure, but also provides an opportunity to better integrate and standardize data collection. Unfortunately, data on race and ethnicity continue to be incomplete across the public health system. These data are critical to identifying and addressing disparities in disease, prevalent healthcare access, and health outcomes. Addressing the social determinants of health is an important way to tackle health disparities. I applaud Congresswoman Bustos' work on social determinants Accelerator Act and Rep. Presley's Anti-Racism and Public Health Act. Too often, social determinants of health is used as a stand-in for addressing issues of interpersonal and systemic racism. So it's important to continue addressing racism in public health. Dr. Walker, how does racism and other structural inequities drive social determinants of health? And specifically, in your experience, how does it affect the health of pregnant individuals and their infants?
Thank you, Congresswoman. We know that social determinants of health matter. And in fact, what we do in a medical setting is only about 10% of what predicts long-term life expectancy. And for that reason, many have written about it, National Academy of Medicine. Even at McMorris, we are trying to figure out how to launch a social determinants of health screener to better understand all of the needs of the child. And we do that in pediatrics from day one of life beyond. But what we know is that some of those predictors actually happen during the maternal period, during preconception, during the pregnancy. And so if we can incorporate those same principles and strategies earlier on, we will have a chance to promote better health long-term.
Thank you. I'd like to submit to the record Addressing Racism and Socioeconomic Influencers, co-authored by the National Partnership for Women and Families and the National Birth Equity Collaborative as part of their Saving the Lives of Moms and Baby series. Also, Dr. What are the current gaps in maternal health data collection?
We know that we have data gaps, and some of those data challenges are around just having accurate, reliable, standardized race ethnicity data incorporated and geocoded at the local level. So having data dashboards is critically important. We are at McMorris trying to geocode information that we have, but we see differences by race ethnicity and who reports their own information. And I think that's an opportunity to provide guidance, to provide technical assistance, and really think about data standards to make it more informative and more useful, to allow the collaborations between public health agencies and health systems to better represent what's going on and address those inequities in care.
Is there data currently being collected by community organizations or the private sector that will be helpful to integrate with the clinical data to better understand maternal health risk factors?
Yes, it is being collected, but I think the challenge is that there often are gaps in what we have. For example, we have some information in our health record that isn't necessarily the same as what's in our health information exchange. And so there just is a process of making sure we're using the best data available, that we're using self-reported race ethnicity, and that we're sharing that same information at the highest quality available with others who are trying to collaborate and really address inequities. But it does take everyone. Otherwise, we're without that data and high quality data, we are challenged in trying to overcome the barriers and leaving people out, particularly in communities of color.
Thank you, and I yield back.
The gentlewoman yields back. Glad it all got straightened out, and thank you, Robin, you're wonderful. The chair is pleased to recognize the gentlewoman from Minnesota, Ms. Craig, for your 5 minutes. Thanks for your patience. And we're thrilled you're on the committee.
Well, thank you so much, Chairwoman Eshoo, and especially for holding this incredibly important hearing today. And thank you to all of our witnesses for being so patient with us and our very many questions as well. I appreciate especially the focus on the drivers of health disparities, race, ethnicity, sexual orientation, gender identity, and social determinants of health, like access to transportation and housing. I represent a district that is equal parts urban, suburban, and rural. And many folks living outside of the major cities don't have reliable access to in-person appointments with medical professionals. I was recently appointed to serve on the Select Committee on Economic Disparity and Fairness and Growth, where I'll have an opportunity to address the economic inequalities faced by rural communities, disparities that have a direct impact on healthcare access and outcomes. I'm also a proud co-sponsor of many of the bills up for discussion today, including HR 2503, the Social Determinants Accelerator Act. Introduced by Congresswoman Bustos, this bill would create a program at CMS to provide grants to state and local governments to develop plans to combat social determinants of health that are negatively impacting health outcomes. With that, my first question is to Dr. Odom Walker. Rural residents in my district face long drive times to the doctor and lack of high-speed internet. For instance, rural Minnesotans seeking inpatient mental health and chemical dependency treatment must travel 3 times longer than urban patients on average. And many in my district have limited to no broadband access, making it very difficult to reach them via virtual healthcare. This lack of access undoubtedly leads to worse health outcomes, and it's not an uncommon story in my part of Minnesota. How could the Social Determinants Accelerator Act, Dr. Walker, which invests in state and local capacity, help rural communities fight these factors that are leading to negative health outcomes?
Thank you for the question, Congresswoman. I think it is unique, and one of the opportunities with the Accelerator Act is to think about how you invest at the local level, to hear from stakeholders, hear from communities about their particular situation and needs. For example, maybe a strategy that could be invested is a telehealth kiosk that's at a local entity, a community center, something that's commonly available to provide that telehealth and broadband access in a stable way. These are the kind of ideas that some have deployed, but it needs scale. It needs, to do more of it where it works, because just putting telehealth into place doesn't necessarily overcome those challenges. And if you have to drive 3 hours to the doctor, that also is not necessarily addressing the challenges of rural communities. So really trying to figure out how to make it unique for the community that we're talking about, and making sure that we're looking at the right lens, the right problem, and with the right data is really important in this bill.
Thank you so much, Dr. Walker. My next question is for Dr. Desalvo. I'm a proud original co-sponsor of the Black Maternal Health Momnibus Act, which includes HR 925, the Data to Save Moms Act. One provision of the Data to Save Moms Act would provide funding to promote representative community engagement within maternal mortality review committees, which are multidisciplinary committees in states and cities that perform comprehensive reviews of deaths during or up to 1 year after pregnancy. Dr. Desalvo, why is it important to gather a diverse range of perspectives in maternal health data collection and reporting processes, including through the elevation of voices and experiences of people from communities most severely impacted by our nation's maternal mortality crisis, particularly communities of color?
Thank you for the question, Congresswoman. We have an expression in public health that the work needs to be done with community, not to community. And that particular part of the Momnibus package describes that so well, that it's not just about experts looking at the data, people in medicine, or even public health professionals. It has to be done with community to understand what's being seen and how to identify appropriate interventions that are culturally appropriate, linguistically appropriate, and are going to meet the needs of the community. So that kind of engagement is essential, really, when we're tackling major public health challenges like maternal mortality, which is higher than any other high-income country and rising in the U.S., and particularly acute for communities of color. So the suite of bills not really helps us understand it's quantitative, it's the voice of community, and as you've raised in the prior question, it's a multi-pronged approach. It's not just about great medical care. We have to make sure people have access to the social needs being addressed as well.
Thank you so much, Dr. Salvo. And with my time expired, Madam Chairwoman, I'll yield back.
The gentlewoman yields back. And now a pleasure to recognize another one of the new members to our subcommittee in this Congress, one of the 5 women on the Democratic side of the aisle, the gentlewoman from Texas, Ms. Fletcher. You have 5 minutes for your questions. Thanks for your patience.
Well, thank you so much, Chairwoman Eshoo, for holding this hearing. And thank you to all of our witnesses for sharing your testimony with us today. Really thoughtful, really insightful. The social determinants of health has been an issue that people in my district in Houston have been concerned about, researching, talking about in ways that are constructive and useful. In fact, we had a town hall on this topic shortly before the pandemic and several roundtable discussions. And so I just really appreciate
the perspective that you've brought today, because of course we have seen during the COVID-19 pandemic that these issues affected outcomes across the country, as many of my colleagues have already discussed today. So I think what's been really useful today is making clear to all of us on the committee the need for data to address the deficiencies in our public healthcare system. We have a great slate of bills to really get at that. And I think it's not just data itself, but more inclusive data that takes into account the social determinants of health as we move forward. And so, Dr. Desalvo, I was really interested in your comments on creating a system with the community to collect data and address social determinants of health. And as we've seen from the COVID-19 vaccine rollout, for example, as of earlier this month, I think June 7th, less than a quarter of Black Americans had received their first shot. And there's a considerable amount of mistrust in the healthcare system among minority populations. And this can be a huge barrier for people getting the care that they need. So from your experience, how can we collect health data in a way that engages impacted communities to better address their needs?
Thank you for the question, Congresswoman. And just to acknowledge Houston as a place that has done some great work, in multisectoral collaboration. And so you all do know how to address social determinants in a public-private sector fashion. With respect to seeing the data and being able to act on it, I'll give you some examples that relate to public-private sector coordination and ways certainly that we at Google have been thinking about partnering, particularly with academics. Early in the pandemic, it was clear that there needed to be more understanding of how COVID-19 was disproportionately impacting communities of color. We worked with Morehouse with the David Thatcher Institute to develop a COVID equity tracker that will also be able to now report out on other inequities or disparities in related diseases like diabetes. So it's an opportunity for us to not only help them with data, but to help build technical capacity that can support public health decision-making. Another more recent example, since you raised vaccines, is work that we've done with the Harvard Medical School and Ariadne Labs, again, to not only provide data insights, but provide technical assistance and partner with them so public health departments, healthcare systems can see where there are vaccine deserts. Who needs extra help getting to a vaccine? Should we put up a pop-up clinic on this corner to reach more people? Those are ways where everybody together can really begin to meet people where they are to get them the services that they need.
Terrific. Well, thank you for that. And I want to move on with the time I have to talk about another issue, which is that many public and nonprofit safety net hospitals serve large populations of low-income and diverse patients, and they're challenged by numerous social risk factors. And some have come together to share and innovate on best practices. And, I've seen that in Houston, especially, we have a really good collaboration, and I think that's a part of how we do things in Houston. But they often lack data platforms that track both medical and social conditions and facilitate access to services that respond to those needs. So, Dr. Walker, in the time I have left, I want to talk about your testimony. You talked about the fact that public and community-based organizations haven't been given the same level of investment as other healthcare organizations. Would you agree that investments for data platforms and safety net providers who often struggle under difficult financial circumstances could drive progress in addressing health inequity?
Absolutely. I think data informs strategy, and without that data, we're often leaving people out, leaving individuals and populations out, and have an incomplete picture of where we need to deploy public health resources or make policy decisions, which underlyingly has been the challenge with exacerbating disparities. I think there's another benefit in the seconds I have just to have data available as a common good instead of having disparate organizations, health systems, and others trying to piece it together.
Wonderful. Well, thank you so much. And I'm almost out of time, so I want to thank you again, Chairwoman Eshoo, for holding this hearing. I am so supportive of the legislation that we've covered today, and I'm grateful for the chance to learn more from this wonderful panel of witnesses. Thank you so much, and I yield back.
Thank you. Let's see. Oh, another one of our wonderful doctors, the gentlewoman from Washington State, Dr. Schreier. You have 5 minutes for your questions.
Well, thank you, Madam Chair, and thank you to all the witnesses who spoke today. Dr. Walker, I am so intrigued by the endless possibilities that data sharing and interoperability offer to improve childhood outcomes. So from the perspective of a pediatrician, I think, wow, it would be really helpful to know which of my patients qualify for free and reduced lunch at school, because that could help guide me in conversations about nutrition and financial stressors, housing, whether the parents have the bandwidth or the resources to help their kids in school. It would even help me focus on community resources like story time at the library. It would also be really helpful to know which of my patients rely on WIC and SNAP, since poor nutrition is associated with adverse behavioral and academic outcomes, but also with tooth decay. And so I could use that knowledge in the clinic to, say, apply fluoride to all my patients' teeth, as opposed to just hoping that they'll follow through and see a dentist. I would imagine that this kind of information would be really helpful for teachers as well, to know which of their students are homeless or relying on social services. So my question for you, Dr. Walker, is how do parents feel about data sharing between public health, social services, schools, and doctors?
Thank you so much for that question. And I often think of the context of families and how as physicians, we're often limited by not having the entire picture. And if I knew that a student wasn't doing well in school, in that clinical interaction, I could ask whether they've been tested or need to be retested for vision screening or have a hearing test, and whether that's a promoter. But I do think that the issue of trust and data sharing is a real one, and one that we're always carefully navigating. But with the right support, the right technical assistance, we could make sure that we have the right data analytics in a protected environment, and allow us to think about how to do this in the right way. Learn from those early adopter states that have already figured some of this out, like Oregon and some that we've mentioned earlier, North Carolina and others.
And
then CMMI can help spread that innovation.
Thank you. I think that brings me to my next question. For Dr. Desalvo, first, I just want to thank you for your work on the app that we use in Washington State that was developed by Google in combination or in partnership with our Department of Public Health, so that if you've got your phone with you and you're near somebody with a positive COVID test, it notifies you. And so given that experience with public-private partnerships and with privacy, I was just wondering, when we talk about kind of a relationship between schools and social services and public health and doctors' offices, how do you address privacy issues related to that kind of data sharing that would help patients and would help? How would you address the privacy issues?
Yeah, Congresswoman, thank you so much for raising the question. And I'll echo what Dr. Walker shared, which is I'm an internist. And always we want to know more about the home context or the social context to understand if that's what's driving some of the uncontrolled diabetes, as an example. I think what I've learned from not only patients, but what people tell you in focus groups and surveys, and you being when the National Partnership for Women and Families does surveys, or when we did them at the Office of National Coordinator, is people want to know that they can have some sense of knowledge about who has access to their data. That's the transparency part. And they very often want it shared with people they trust. They just need to know that they have some control over how that happens. And in this space that you're describing, which technically some of those entities fall outside of HIPAA, there's been a lot of work and thinking about how, as we're going to as a healthcare system and a public health system, be more inclusive of data, give consumers that choice and control over data sharing. I'll just call out the particular place that provides that's been doing the thinking on it. It's a group called the Carin Alliance, not as in my Karen, but CARIN, working with consumers and others to understand consent.
Thank you. One more question for you. There's a lot of what ifs about COVID and how we handled it, what could have gone better. And I think about whether if we had a really modernized, interoperable, digital, wonderful health infrastructure, if we could have used, say, wastewater testing for COVID in order to really direct our public health response. And now we're talking about tracking COVID-19 variants in one of the bills being discussed today. How could an optimally situated public health department use data about new variants to curb spread of disease?
In a few seconds, just to say what was desperately missing for public health was not only the nowcasting, the data that Dr. Blauer was able to provide the country, but the opportunity to forecast and be able to predict where the virus was going to spread and where variants would spread into the future. We've partnered to create a system called Global.Health with Global Public Health to begin to advance that work in forecasting. But the bills that you have before you, the kind of work that Congress is doing is thinking about not just the data, but the infrastructure and the people who work on that data around it. So it's got to be a system in order to prevent the kind of outcomes that we had in this last pandemic.
Thank you very much. Yield back.
Gentlewoman yields back. I'm getting a kick out of myself saying yields back because I've allowed so many members to go way over. So they really don't have any time to yield back, but we've accommodated everyone. I hate to cut people off because every question and answer is just so important to us. And now last, but certainly not least, a real value added new member to the committee, the gentlewoman from Massachusetts, Congresswoman Trahan. We have 5 minutes for your questions. How about 5.5? What's that?
Oh, the joys of going last. I get it a little extra time. No, thank you, Chairwoman Eshoo, and thank you to all the witnesses here today. It's been so informative. There's no question public health data is multifaceted, and it resides in different agencies and institutions that span across, social services, education, behavioral science, and so much more. And improving data collection and closing those gaps is critical to our not only addressing the ongoing COVID-19 pandemic, but all of our other public health challenges. In 2015, my home state of Massachusetts recognized the value that data innovation has in inadequately addressing public health crises and passed Chapter 55, a law which authorized the Massachusetts Department of Health to link multiple traditionally siloed data sets with insight into the opioid crisis, an approach that had never been before sort of cross-studied. And the reports and underlying analysis drew insight from a database that linked mental health data, jail and prison data, vital records, substance addiction treatment data, ambulance encounter information, the state's all-payer claims database, and others. And based on all those insights from Chapter 55, the reporting and the data visualizations, measures like limiting first-time opioid prescription to 7 days, a first in the nation measure, was signed into law. So in 2017, when opioid-related overdose deaths fell for the state population as a whole, data showed it rose by 44% for Black males. And this data led the health department to develop a community-based public awareness campaign to focus on and reach Black men. So, Dr. Desalvo, I'll start with you. Can you just speak once again to how cross-departmental sharing of information can be used to drive policy to combat public health crises in the country, such as the opioid epidemic?
Yes, thank you so much, Congresswoman, for reminding all of us that bubbling under the surface is another epidemic that was here prior to the pandemic and is beginning to reemerge. So we have to, when we're thinking about building public health data systems, we have to remember they need to be useful not only for communicable disease, but for other conditions that affect communities. Opioids being a great example. And Massachusetts, in this case, as in others, has been smart about leveraging multiple data sources that tell the story of a person's health or a community's health beyond just that healthcare episode. You're describing data sources that describe their social and human services interactions, as well as their healthcare needs. And all of that will be necessary if you're going to take a multi-pronged approach to developing community interventions to drive equity and address social determinants as well as medical needs, and then measure the outcomes as you described. So takeaway for me from that lesson you all have been teaching the country is multiple sources of data needed to tell the story of somebody's health or needs and take action in a multi-pronged way at the community level and know if we're making a difference in outcome. And we need to build those systems to be agile so they can address the multitude of community needs that are there on the front lines.
Thank you. One of the things that was made clear to me is that in order to collect robust data to tackle these public health crises, we must heavily invest in both public health infrastructure and workforce in the field of data and informatics. And over the years, researchers have discovered a large variety of human biases that shows the things that people understand, the things that people understand or believe do not always reflect what is actually happening in the real world. And so question for you, Dr. Walker, can you just speak to how investing in a diverse pipeline of individuals and health data analytics can work to mitigate, unconscious bias in the analysis of data that drives our policies?
Thank you for that question. I think having a diverse workforce is essential. It allows you to interpret the data in the right way, but I'd also say it's not just about the professional workforce, it's also trying to figure out how to have community and stakeholders involved in that data interpretation stage. So thinking about piecing together information, whether it's for the opioid pandemic or other inequities, we know that bringing them together is critically important. It requires an investment of expertise, but also of what you do with it and how you put it out to the world, whether it's a data dashboard that we found incredibly valuable in the past year and a half, or whether it's putting it in the hands of local community advisory boards who can say whether for their community it's more important to have broadband investments or to think about transportation. So I think it's essential, and we just have to figure out where to get started.
Yeah, well, thank you. Making that data consumable is job number one, so we know how to act on it. So I'm out of time, even though the chairwoman was gracious enough to give me a little bit more. So thank you so much for all of your input today. It's very helpful in our policy making. I yield back.
The gentlewoman yields back. Well, we've come to a conclusion of all of this time with members asking their questions. I want to thank each one of the witnesses. You've been with us for a long time today, almost 4 hours, 20 minutes shy of 4 hours. So I hope you had breakfast because you certainly have missed lunch. Dr. Desalvo, Dr. Batra, Ms. Blower, Dr. Sayed, and Dr. Walker, you've all been terrific. Now, members have 10 business days to submit additional questions for the record. So witnesses, we're asking you to please respond as promptly as possible to the written questions that are going to be submitted to you. And now I want to go to my friend, the ranking member of the subcommittee, Mr. Guthrie, because we have 23 documents to be submitted into the record, and I'd like to request unanimous consent, but I need your consent. Is Mr. Guthrie with us?
Our side consents.
There you are. Thank you very much. All right. So there is unanimous consent to enter these documents into the record. And I think that's it. So thank you, everyone. Bravo to each one of the witnesses. It was a terrific hearing, and we're going to move these bills. We have 13 today in this legislative hearing. I think there's 6 or 7 that are bipartisan. So we're always pleased and proud about that. But all of them are a reflection of the very important work of many members of Congress in writing the legislation and having our subcommittee have the honor of having a legislative hearing. So God bless all of you. God bless our country. Thank you for being witnesses, and the Subcommittee on Health will now adjourn.